So good evening all. Is it audible? First of all, is the screen visible? Right. So right. I am Dr. Vamsi, the faculty of medpg team. So today I'm going to deal top INICET questions for medicine. As this INICET exam is just 2 weeks apart, we started this program where we are going to cover all high yield topics and all previous year questions from the last 3 years INICET papers. So how this class is very important is INICET exam is always about repeats. If you see one topic, they'll choose one topic, they'll try to give topics from the topic, definitely from the base to the end. Each and every corner they'll touch the topic. After entire topic is completed, then they will leave the topic and go to the other topic. So knowing the topics of INICET exam is very, very important for the coming exams. And not only that, same topics in the basic simple version they're used to ask in the NEET exam also. So what we're going to do in this class, we are taking 2 classes today and tomorrow, 2 hours each. So what we're going to deal, we are covering about 180 to 190 bits. So what we're dealing is, we are just taking the important topics and also all the questions. We are covering the topics and we are ruling out how to approach to the answer and how to answer the question and how to rule out other options. And also we are dealing with small concepts related to that questions, and also any other extra points they can ask in the exam related topic also will cover. Right. So please do focus. And small request to everyone, in actually the weather is very bad and it's completely thunderstorm and so much of power cut and network interruption is there. That is the reason we postponed the class for 1 hour also. So if any network interruption has happened, please stay in the class for 5 minutes. I will rejoin back in 5 minutes. Right. So let us start our class. We'll start with the right. Right. So we'll start with the first question. Right. So what is the first question dealing about? All of the following are causes of secondary hyperparathyroidism. So they're asking about secondary hyperparathyroidism, right? Right. 1 minute. Right. So they're asking about secondary hyperparathyroidism, right? So before knowing secondary hyperparathyroidism, you have to know what are the different types of parathyroidism, hyperparathyroidism. In this, one is primary hyperparathyroidism, other is secondary hyperparathyroidism, right? So what is hyperparathyroidism? That means parathyroid gland is producing more amount of parathyroid hormone. Right? In this primary hyperparathyroidism, what is the thing? There is no stimulus to the parathyroid gland, but the parathyroid gland itself is producing more amount of hormone. Right? There's no stimulus to parathyroid gland, but parathyroid gland is itself producing more amount of parathyroid hormone. That is called as primary. But what is secondary? In the secondary, what is there? Secondary, here parathyroid gland is completely normal, but it has some stimulus. Because of some stimulus, the parathyroid gland is producing more and more amount of hormone. And what is the most common stimulus of secretion of parathyroid hormone? That is your calcium, low calcium. Hypocalcemia is the important stimulus for producing more amount of parathyroid hormone. Right? So this is the primary and secondary. Primary is the one, gland is abnormal, gland is producing more amount of hormone without any stimulus. In the secondary, gland is completely normal. Some stimulus is there, like hypocalcemia is there, that is stimulating parathyroid gland to produce more amount of hormone. So what is the question asking about? Secondary hyperparathyroidism. If you see this chronic kidney disease, because of chronic kidney disease, you will have vitamin D deficiency. Yes, that lead to decreased calcium. Yes, that will stimulate the parathyroid gland. So you have to see what are the conditions causing hypocalcemia. All these conditions will lead to secondary hyperparathyroidism. Right? Similarly, vitamin D deficiency, yes, it will decrease the calcium. Because of this, there is secondary hyperparathyroidism. And malabsorption, yes, malabsorption, what is happening going? Again, calcium is not absorbed, vitamin D is not absorbed, again, there's decreased calcium. So all these things are decreased calcium, hypocalcemia, stimulating the parathyroid gland. So secondary hyperparathyroidism is there. But what is there here in the fourth option is parathyroid adenoma. Here, what is there? Here, there is no problem in the calcium metabolism. The problem is in the gland itself. The gland only overactive and it's producing more amount of hormone. So this is primary hyperparathyroidism. So the answer for the question is parathyroid adenoma because it's a classical example of primary hyperparathyroidism, right? So all these three are secondary hyperparathyroidism. In this most important NEET question, what they're asking is, what is the most common cause of primary hyperparathyroidism? What is the most common cause of primary hyperparathyroidism? This is a simple bit. They're asking the NEET question. But in the same way, in the concept is they're asking the INICET question. What is the most common cause? The most common cause is parathyroid hyperplasia and parathyroid adenoma. Okay. Of these things, the parathyroid adenoma is a very, very common cause. This is the most common cause. Right? Simple? Clear. So let us see, this is what I discussed. In the hyperparathyroidism, you have two types are there. One is primary hyperparathyroidism, other is secondary hyperparathyroidism. But there is one more entity, very, very important. That is what is called as tertiary hyperparathyroidism. This is a potential NEET INICET question. Right? Let us discuss. So primary hyperparathyroidism, as I discussed, gland only abnormal. Gland is abnormal. Okay, gland is overstimulating and producing the hormone. The main thing is parathyroid hyperplasia and other is parathyroid adenoma. Okay, of these things, parathyroid adenoma is very, very important. It's the most common. In the secondary, the parathyroid gland is normal, but it has some stimulus. That stimulus is decreased calcium. Any condition which is decrease in the calcium will stimulate the parathyroid gland, like your CKD or your vitamin deficiencies or your malabsorptions, anything. Right? And then comes the third, tertiary hyperparathyroidism, very, very important. So what is going to happen? Let us see this thing, very important here. So whenever the secondary hyperparathyroidism like CKD patient is there or any vitamin deficiency patient is there, because of decreased calcium, it is stimulating the parathyroid gland. If it is there for long duration, if the secondary is there for long duration, because of long duration, it is going on, stimulating parathyroid gland. Okay, continuously stimulating your parathyroid gland. Now, what will happen? This parathyroid gland will become autonomous. It will become autonomous. Okay, so what is autonomous? Now this parathyroid gland become villain. It's like dawn. It don't listen to anyone. It just produces parathyroid hormone. That is called as tertiary hyperparathyroidism. This tertiary is nothing but your autonomous. It is autonomous gland. Gland has become autonomous. Okay, so initially because of hypocalcemia, gland is stimulated and producing parathyroid hormone. So usually if it is a short duration, when calcium levels restored, parathyroid gland becomes normal. But if it is long-term stimulation is there, then because of hypocalcemia going on stimulating the parathyroid gland, now the gland becomes autonomous. Then even the calcium levels normal, it still secretes your hormone. That is called as tertiary hyperparathyroidism. This you can see in case of late CKD, late stage of CKD. This is a potential question again, right? Till now they asked about primary and secondary, but recent they are going to ask tertiary hyperparathyroidism also. Only one example, late CKD. Right? Clear? Right. We'll go to the next one. Right. Let us see this question. A 25-year-old was present with recurrent urinary stones, right? And again, pathological fracture. Very important here. Recurrent urinary stones and pathological fracture. Why recurrent urinary stones? Because of the increased calcium levels. Because of increased calcium levels, there is nephrocalcinosis leading to recurrent urinary stones. And there is a pathological fracture. Why pathological fracture means something happening to the bone resorption is more, pathological fracture happens. So blood reports show high calcium and PTH, which is what is the diagnosis now? So because recurrent urinary stones due to high calcium levels and also pathological fracture, I can say it's mainly because of your hyperparathyroidism. First of all, you have to know what is the diagnosis. Because hyperparathyroidism, so what is the parathyroid gland doing? This parathyroid hormone. Okay, so parathyroid hormone always helps in increasing the calcium levels in the blood. It increases calcium levels in the blood. How it increases calcium levels? By increasing the absorption of calcium from the gut and also by doing bone resorption. By doing bone resorption, there will be increased calcium in the blood. By doing bone resorption, bone will lead to fracture of the bones. Right? And one more important function of parathyroid hormone is it is phosphate thrashing hormone. Mnemonic is phosphate thrashing hormone. Okay, that means it always cause the phosphate to go out into the urine. It always decreases the phosphate levels in the blood. Okay, these are three functions of the parathyroid hormone. Right? If parathyroid hormone levels are high, you will have increased calcium levels. That's why you'll have recurrent urinary stones, and you'll have bone fractures. That's pathological fracture. So whenever these two combinations are there, definitely you have to think about your hyperparathyroidism. Right? Now, when say hyperparathyroidism, what is the question you're asking? We understood the diagnosis is hyperparathyroidism. Now the question is which of the following test is performed for localizing the parathyroid gland? Okay, so if it is a hyperparathyroidism, what is the following test to be done to localize the parathyroid gland? What scan can be done? For example, if you want to scan the heart, you have to do echo. If you want to scan the lungs, you have to do CT chest. Like parathyroid gland, what scan to be done? They're asking. Let us see the options. The system may be scan, FDG PET, ultrasound, FNS is there. Okay, so they're asking what? To localize the parathyroid gland, you cannot do FNAC. It's an invasive procedure. You're doing FNAC means you're taking fine needle aspiration from the gland. So that is not a localizing technique, right? Ultrasound, with just ultrasound, you cannot able to identify the parathyroid gland or parathyroid adenoma or something, right? FDG PET is a very invasive, very costly scan, which will help to localize all the organs. That is also not the thing. The important thing is system AB scan. Okay, so what is this thing is technetium 99M system AB scan. So this scan is the one which helps to localize parathyroid adenoma, Okay. So whenever you're thinking there is hypercalcemia is there, whenever there is some pathological fracture is there, when you're thinking primary hyperparathyroidism, then you have to localize this parathyroid gland, whether adenoma is there or not. For that, what scan you have to do? System AB scan. This technetium 99M system AB scan, which helps to localize your parathyroid adenoma. That is your question, right? Simple. So let us discuss few points about hyperparathyroidism. So what I discussed, hyperparathyroidism, your PTH levels are increased. Okay, because your PTH levels are increased, what is going to happen? I am saying you, it always increases your calcium levels. Because increased calcium levels, it leads to what's called as renal calculi. That is called renal stones. Right? Similarly, it also leads to what? Bone resorption. Increased bone resorption leads to pathological fracture. Okay, bone groans. Very important. And again, this calcium leads to so much of constipation and it leads to what's called abdominal pain. So the clinical triad is easy important: renal stones, abdominal moans, and bone groans. This is the mnemonic they used to say. Okay, renal stones because of your hypercalcemia, abdominal moans because of the calcium lead to hyper constipation, and bone groans because of your pathological fractures due to hyperparathyroidism induced bone resorption. Right. So what is the biochemical profile? Very simple. I said there is always increased calcium, right? And secondly, there is decreased phosphate. Very, very important because it's a phosphate thrashing hormone. It will thrash the phosphate. It always helps to eliminate the phosphate from the blood. So decreased phosphate is very important. So helps to diagnose. You have to do serum PTH level, or you can localize. You can do system AB scan. Very, very important. That's it. These are the only things you need to know about hyperparathyroidism. So what is primary, what is secondary, what is tertiary? Very important. After this, how will you identify clinically renal stones and then abdominal moans and then bone groans, then biochemically increased calcium, decreased phosphate, and then to diagnose serum PTH levels and system AB scan. Right? Clear? Right. Let us go to the next thing. This again same. Now patient with hypercalcemia, right, is evaluated for hormonal regulation of calcium homeostasis. Which of the following decrease serum parathyroid hormone levels? They're asking what are the drugs that will decrease serum parathyroid hormone levels. Very, very important thing. Why it is important is, okay, in the entire pharmacology textbook, there is only one thing which will inhibit your parathyroid hormone. One thing which inhibits parathyroid hormone. That inhibits your parathyroid hormone. What is the thing? That is what is called as active form of vitamin D. Active form of vitamin D. Very important. Very, very important. Okay. This is the only thing which can inhibit your parathyroid gland. The rest all nothing can inhibit your parathyroid gland. If there's decreased calcium, yes, it will stimulate parathyroid gland. But increased calcium, it won't stimulate parathyroid gland. That's it. It won't inhibit the parathyroid gland. But this one active form of vitamin D is the only thing which can inhibit your parathyroid gland. So that's what they're asking. It is calcitriol is the answer. Right? What is this? See the other options. What is risedronate? Risedronate is a bisphosphonate. It's a bisphosphonate. So what is it doing? It is not doing anything with the parathyroid gland. It is inhibiting the osteoclast. So it is not related to our question. Right? Simple. And next is furosemide. You know what is furosemide? It's a loop diuretic. Nothing to do with your parathyroid gland. It's not acting on parathyroid gland. And then cholecalciferol. It is your again inactive form of vitamin D. Inactive form of vitamin D. Okay. This calcitriol is the only one which is active form of vitamin D, which can inhibit your parathyroid gland. Right? So they're asking only simple thing, which of the following decrease serum parathyroid hormone levels? Active form of vitamin D you have to check, that is calcitriol. Right? Or simply they can ask 125 dihydroxy cholecalciferol, which is also active form of vitamin D. Both are same. Right? Right. So let me see one thing. So as I discussed in the case of CKD, there is always decreased calcium levels. Yes, because there is no 1-alpha hydroxylase, no vitamin D, so hypocalcemia. Because of hypocalcemia, yes, there is increased PTH. That is what is called as secondary hyperparathyroidism. We discussed. Okay, but when calcium is low for a long duration of time, it is going on stimulating parathyroid gland. So it is slowly progress to what? That is called as tertiary hyperparathyroidism. That is, gland become autonomous. Okay, so now you cannot, if more gland is stimulated, more hormone is, what is going to happen? Bone resorption and pathological fracture can happen. So you have to control the parathyroid gland. The only thing that can control the parathyroid hormone is your calcitriol. So calcitriol is a drug of choice. That is the reason you always give calcitriol for patients of CKD, everyone. Okay, this calcitriol is drug of choice. It's to decrease your parathyroid hormone, decrease your parathyroid hormone. Okay, and then important thing is, you always in the CKD, your goal of PTH, your goal of parathyroid hormone is less than 150 nanogram per ml. That's it. These two are the new points they can ask you. Right? Simple, clear. So these are all the things, just for 4 or 5 concepts, bits they asked about hyperparathyroidism in the recent 3 years. Everything we covered. What is primary? What is secondary? What is tertiary? Tertiary very important. Autonomous you can see in CKD patients. Right? What are the clinical features? Renal stones, abdominal wounds, and bone growths. Very important. Right? Pathological fracture because of increase in resorption. How will you diagnose? Decrease calcium, increase phosphate because increase calcium and decrease phosphate because of phosphate thrashing hormone. Right? And system AB scan, it helps to localize the parathyroid gland. To control the parathyroid hormone, only one thing is that is calcitriol. In the CKD, the target of PTH is less than 150 nanograms per ml. Clear? Right. Let us go for another thing. Right. So let us see this question. What is the most common type of pituitary adenoma? They're asking what is the most common type of pituitary adenoma. If you see this pituitary gland, this is your pituitary gland. Pituitary gland, for example. Okay. You have what is called as anterior pituitary and posterior pituitary. Anterior pituitary and posterior pituitary. Right? This anterior pituitary has multiple cells which produce many hormones, but posterior pituitary has only 2 types of cells which produce 2 hormones. One is ADH, other is oxytocin. We all know anti-diabetic hormone, also called vasopressin, and other is oxytocin. Right? This anterior pituitary gland contains 5 different types of cells. Very important. 5 different types of cells. Very important. Okay. One is somatotropes. Please remember in the same sequence. Okay. Somatotropes, lactotropes, okay, gonadotropes, thyrotropes, and corticotropes. Okay, somatotropes, lactotropes, gonadotropes, thyrotropes, and corticotropes. These somatotropes are the one which is producing your growth hormone. These lactotropes are the producing your prolactin. These gonadotropes are producing your this FSH and LH. Thyrotropes is producing your TSH, and corticotropes producing your ACTH. Simple, very simple. Now, what is the question they're asking? Out of if pituitary adenoma happens, which of the following cells are most commonly responsible for your pituitary adenoma? They're asking, right? So this is just a memory-based question. The important thing is it's always prolactinoma, right? So what is the confusing point here is, in the case of pituitary adenoma, the most common cause is because of your lactotropes. Is because of your lactotropes. So always prolactinoma is a very important cause of your pituitary adenoma. If there is no prolactinoma, the other thing is non-functioning adenoma is another option you have to put. Non-functioning adenoma. What is non-functioning adenoma? Let us come to the previous slide here. We discussed there are 5 types of cells like somatotropes, lactotropes, gonadotropes, thyrotropes, and corticotropes. Apart from this thing, there are certain cells. There are certain cells which are non-functioning cells. They're not producing any hormone. They're called as non-functioning cells. Sometimes these cells only can proliferate and form adenoma. Okay, so the first best answer is prolactinoma. After this, non-functioning adenoma. If that is not there, then this is a growth hormone secreting tumor. So this is the sequence. Your somatotropes, right? The most common cause of pituitary adenoma is mainly prolactinoma. If prolactinoma is not there, go for non-functioning adenoma. If not there, then go for growth hormone secreting tumor. Right? Important. So this mnemonic is very important. Somatotropes, lactotropes, gonadotropes, thyrotropes, and corticotropes. Why? Why this mnemonic is important? That is take care. So why is important? Because so if there is any pituitary insufficiency, if there is any some pituitary gland insufficiency is there, the hormones will decrease in this following order. First somatotropes will decrease, then lactotropes, then gonadotropes, then thyrotropes, then corticotropes, ultimately corticotropes. So that is the reason you have to remember in this sequence. Right? That's it. Simple thing. They're asking simple. This is a neat question only. What is the most common type of pituitary adenoma? Pituitary adenoma can happen from any of the cells present in anterior pituitary or posterior pituitary. So posterior pituitary produces only two types. One is ADH and oxytocin. Anterior pituitary has 6 types of cells: somatotropes, lactotropes, gonadotropes, thyrotropes, corticotropes, and non-functioning cells. Any of these cells can proliferate and form adenoma, but out of all, prolactinoma is the one which is very, very most important cause. And then after that, there's non-functioning cells, then somatotropes. Right? One more important question. This is very, very important. Whenever there is pituitary insufficiency is there, the hormones will decrease in the following order. First, somatotropes will decrease, so growth hormone deficiency will come. Then comes your lactotropes, then comes your gonadotropes, then comes your thyrotropes, then comes your corticotropes. So depending upon the age, the symptoms will happen. So how the INICET people will ask the questions in this thing is, for example, in a child, pituitary insufficiency happen. So what is the first thing you will notice? In a child, growth is very important. Somatotropes are lacking, so you'll have growth hormone deficiency. Right? But similar question, if they ask in the adult patient, if there is pituitary insufficiency, what is the clinical manifestation you will see? In the adult patient, there is no role of somatotropes. Already growth had happened. Okay, lactotropes, no. Then they have gonadotropes. They'll have some amenorrhea. They'll have some gonadal failure. All these things will happen. Right? That is important part of this question. So first somatotropes, then comes lactotropes, then comes gonadotropes, then drops thyrotropes, then is corticotropes. Right? So in the child, pituitary insufficiency will seen as growth failure, because the first cells that is going somatotropes, you will see growth failure. But in the case of adult, what is going to happen? Pituitary insufficiency, even though somatotropes are reduced, you cannot see growth failure because already the adult had attained sufficient growth. So what you can see is your gonadal failure, that is your amenorrhea. You can see. Okay, important, very important. So this is a new bit they can ask from this. So just pituitary adenoma they asked. We just derived one more important bit, which is covered in the previous 5 years. Right, clear? I think it is clear. Right. Any doubts, you can just message. We can discuss those things now. Right. Let us go to the one more question. Very important, very tough question, and very, very definite question. In every year, every session, they will ask this question. I don't know, this hyponatremia will come throughout your life. Well, whichever branch you select, hyponatremia will come throughout your life. Right. Let us see what is asking. The hyponatremia in a hypovolemic patient in case of severe diarrhea is due. What is asking? The hyponatremia in hypovolemic patient. That means he's asking about hypovolemic hyponatremia. Hypovolemic hyponatremia. Okay, the patient had a severe diarrhea. Because of this, patient experienced hypovolemic hyponatremia. Now, what caused this hypovolemic hyponatremia? That is what he's asking. Right? Let us see this thing. It is not because of decreased reabsorption of sodium from kidney. Let us see the options. For example, there is hypovolemia is there. That means his blood volume is decreased. Whenever his blood volume is decreased, his tubulo-glomerular feedback will increase, and kidney always try to absorb the sodium. It is not decrease the sodium. So this is not the option. Clear? And then decreased absorption of sodium from the gut. So gut absorption does not correlate with the hyponatremia, or it's not the option. And decreased secretion of aldosterone. Aldosterone also it's not important. The important question is option is increased secretion of ADH. So what is this thing? Let me explain. Once I explain, you'll understand this thing. So let's come to the question. So hypovolemic hyponatremia. So what is the main cause of hyponatremia in this patient is asking? The option is increased secretion of ADH. 1 minute. It's not visible on the screen. Right. uh, Sorry, this is the disturbance that's happening because of internet. So is it audible? Everyone is there? Right. So let us see this thing. So what is asking? What is the cause of hyponatremia, hypovolemic hyponatremia? Right. So before discussing about this concept, let me discuss about what is called as ADH, anti-diuretic hormone. The name itself says it is anti-diuretic hormone. So what is it doing? It is anti-diuretic. That is, it is not promoting diuresis. So that means it is not promoting urine to go. That means it is not promoting free water to go in the urine. Anti-diuresis. It is helping absorption of the water. Right. So where is acting? Very, very important. These things very, very important. Yeah. So where is happening? This ADH is always acts on what is called as your collecting duct. This ADH acts on the what is called collecting duct. So for example, this is your distal collecting duct. Okay, this is a distal collecting duct. So this is your epithelial cell, distal collecting duct cell, and this is your lumen. This is a lumen. This is your blood. This is your blood. Okay, so that's what I'm saying. Let's discuss about your ADH. So what you are discussing, we are discussing about your ADH. What is the action of ADH? So ADH helps in absorption of the water, free absorption of water. So how is it doing? This ADH, it acts on a receptor called as vasopressin receptor. That is what is called as V2R. Okay, this ADH acts on the V2 receptor. That leads to what? Very important. It leads to increase in cyclic AMP. Increase in cyclic AMP. Very, very important. Just because there's increase in cyclic AMP, what it will form? It will help to make water channels, that is aquaporin channels. It leads to formation of what? Aquaporin channels. These are the aquaporin channels. Very important. Aquaporin 2. Okay. Once these aquaporin channels are formed, then your free water from this lumen is getting absorbed and coming into the blood. So this is the process happening. Very, very important. This ADH acts on the distal collecting duct, where it acts on receptor called as B2 receptor. In the bit, once it's stimulated, it leads to increased production of cyclic AMP. Once cyclic AMP is stimulated, it will form aquaporin 2 channels on the luminal membrane. Because of this thing, so much of free water is getting absorbed into the blood. So in this way, it helps in absorption of the water. Right. So this is what the action of anti-diuretic hormone. Right. So let us see what are the things, what are the different types of hyponatremia, what are things with this. See. So one more important thing I want to say is for this ADH, the main important stimulus, the stimulus for secreting ADH, the stimulus for ADH is always increase serum osmolality. Very, very important. Increase serum osmolality. So once there is serum osmolality is increased, what our body will think, oh, serum osmolality is increased. That means water level in the blood is decreased. So we have to get more amount of water. So immediately it will secrete ADH. Now ADH acts on V2 receptors through cyclic AMP, aquaporin 2 channels. It helps in absorption of free water. Your serum osmolality will be normalized. So the main stimulus for ADH is your serum osmolality. And one more stimulus is important, that is your decreased effective arterial blood volume. What is this thing? Decreased effective arterial blood volume. So the amount of blood that is present in the artery, if it is less, then also less water is there, less blood is there. Our body tries to absorb the water, so it will stimulate your ADH. So these two are the very, very important stimulus. One is your increased serum osmolality. It will directly stimulate the ADH. It is directly stimulate the ADH. Okay. And then ADH will help in absorption of free water and decrease the osmolality. And there's decreased effective arterial blood volume. Whenever the effective arterial volume is less, that means whenever the blood volume in the arteries is less, immediately our body tries to increase ADH so that free water is reabsorbed. Clear? Right, clear? Just 1 minute. Clear? So the thing is, so ADH, it's anti-diuretic hormone. It acts on the distal part of the collecting duct, where it acts on the cells. It acts through V2 receptor. Through receptor, there is increased cyclic AMP. Then there is formation of what? This aquaporin 2 channels. This aquaporin 2 is very, very important. Need to push, right? Because of this, there's a free water reabsorption to the blood vessels. Right? Very important. Now, what are the stimulus for ADH we discussed? One is increased serum osmolality. Then there is decreased effective arterial blood volume. Now let us see what is going to happen. So let us say this is the hyponatremia. You know what are the different types of hyponatremia? So there are three types of hyponatremia. One is hypovolemic hyponatremia. hypovolemic hyponatremia. Okay. Other is euvolemic hyponatremia. And other is hypervolemic hyponatremia. Hypervolemic hyponatremia. These are three different types of hyponatremia, as we know. So hypovolemic hyponatremia, what is going to happen here in pathology? The simple thing in hypovolemic hyponatremia, okay, your water content, total body water is decreased, okay, and your sodium is also decreased, right? But your sodium content is decreased more than the water content, right? How it is, we will see first. For example, in the present scenario, patient is having diarrhea. Because of diarrhea, what is going to happen? He is having total body water is decreased. Because of diarrhea, because of your acute gastroenteritis, the patient's total body water is decreased. Accepted. Once his total water decrease, along with the water, sodium also will decrease. Sodium also will decrease. So once it decreases, what is going to happen? The serum osmolality is decreased. Serum osmolality is increased. Because water is decreased, serum osmolality is increased. Then our hero comes, that is your ADH. Your ADH also will increase. Okay. Once ADH is increased, it helps in absorption of free water absorption. Okay. Now only free water is absorbed, not the sodium. Only free water is absorbed. So that is why only free water is absorbed. So total body water will become normal or very lesser. But sodium is still very low. That is why your total body water is less and sodium is very, very low. So this is the mechanism of hypovolemic hyponatremia. It's mainly because of your increased ADH. Okay, it is not because of GI loss or something. In diarrhea, because of this diarrhea, there is loss of blood water. There is also loss of blood sodium also. Then there is decreased total body water. There is decreased sodium also. Once because of this thing, there is increased serum osmolality. Just because increased serum osmolality, there is increased ADH. Now ADH absorbs the free water. Only free water, but there is no sodium because water is getting absorbed. Okay, water is getting filled, but sodium is not getting absorbed. So sodium has a hyponatremia. That is called as hypovolemic hyponatremia. This hyponatremia is mainly because of increased secretion of ADH. Right? So this is what we discussed here. Right? Clear? Right. Here, what are the questions you're asking here? Let me explain this thing here. So first thing, in the NEAT or something, this ADH acts on the distal collecting duct. Very important. This acts in distal collecting duct. Okay. It acts through receptor called as V2 receptor. Very important. Very, very important. And this V2 receptor, the neurotransmitter is cyclic AMP. That is also the messenger is cyclic AMP. Right, very important. And the cyclic AMP produces aquaporin 2. 2 is very important. Aquaporin 2 channels. Okay, they'll ask you question 1, 2, 3, 4, but 2 is very important. Aquaporin 2 channels, which helps in absorption of water. Right? Aquaporins, if they ask this important thing, this aquaporins, if you see, there are 4 types of aquaporins. Aquaporin 1, aquaporin 2, aquaporin 3, aquaporin 4. This aquaporin 2, 1 is present in the proximal current tubule, and 2, 3, and 4 are present in the distal collecting duct. Simple. So this is again a previous year question, which is aquaporin 1 present in the PCT. That is 1. Okay, NEAT asked only how many aquaporins. There are 4 aquaporins, 1, 2, 3, 4. 1 is there in the proximal current tubule, and 2, 3, 4 are in the distal collecting duct. Right? Simple, clear. So that's what I'm discussing. So now you see this thing, the hyponatremia in hypovolemic patient, that is hypovolemic hyponatremia, is because of what? In severe diarrhea. And because of severe diarrhea, there is decreased water content, decreased sodium content. That means there is increased serum osmolality. Because increased serum osmolality, again there is increased ADH. Increased ADH, there is only free water reabsorption, not sodium reabsorption. So there is a hyponatremia. It's all because of increased secretion of ADH. Very important thing. Right, clear? So that's what I discussed. And this again one more important question. What are the different stimulus for the ADH? The stimulus is increased serum osmolality leads to increased ADH and decreased effective arterial blood volume. Right? Any doubts? This is a little bit tough question. Any doubts you can ask? Or else you go to the next question. Right? Simple thing. If you understand the basic concept, the INICET questions are very easy. Right. So let us go to the thing. One more question they are asking about hyponatremia. A 60-year-old woman treated for severe hyponatremia. The patient has severe hyponatremia. Then aggressively our PGs and all, they have treated severe hyponatremia. After treating, the patient develops acute onset mutism. That means patient completely mute. Quadriplegia, very important. There's no, all 4 limbs are gone. Pseudobulbar palsy after 3 days. Right? What is this syndrome? The patient is mute. The patient has quadriplegia. It's nothing but your locked-in syndrome. What is locked-in syndrome? The patient is quadriplegia. That means, what is locked-in syndrome? Patient is in quadriplegia. That means patient all 4 limbs are not moving, and mutism. He is locked in. That is called locked-in syndrome. And MRI shows central pontine involvement. When you do MRI, it's called central pontine involvement. So what is the diagnosis? We can know when you see hyponatremia, whenever you treat hyponatremia, you have to treat cautiously, you have to treat very slow rate, because elderly patients, if you treat very aggressively, it will lead to what is called demyelination of the pons. That is what is called a central pontine myelinolysis. Central pontine myelinolysis, very important. Okay, why it is happening? Because whenever you increase the sodium concentration very rapidly, the osmolality will increase very rapidly. That will lead to what is called as your central pontine myelinolysis. This is also called as osmotic demyelination syndrome, ODS. Okay, this particularly affects the pons and also your basal ganglia and even your cerebellum, but more commonly involves pons. That's why pons lesions always have locked-in syndrome. That is quadriplegia, mutism. That is locked-in syndrome. Okay, and MRI shows central pontine involvement. Okay, so this is what the questions. Let us see the question. The questions are simple. Say treat with severe hyponatremia. That is the clue. After treating hyponatremia, patient developed quadriplegia. It's again involved in the pons. So pseudobulbar palsy also. So MRI shows central pontine involvement. So diagnosis: central pontine myelinolysis or osmotic demyelination syndrome. Very, very important thing. Let us see other options. Why it is not Guillain-Barré syndrome? You know, Guillain-Barré syndrome, it always ascending paralysis. Antecedent, there is some viral infection will be gastroenteritis or respiratory infection will be there. Areflexic paralysis. What did they mention? Only just 60-year-old man treated for hyponatremia. They didn't mention any history of any GI loss, history of any some respiratory infection. Nothing they have mentioned. So this is not the thing. Multiple sclerosis. Okay. 1 minute. Okay. Right. Then multiple sclerosis, again, multiple sclerosis nothing to present as say some optic neuritis, some internuclear ophthalmoplegia, all these things. That is also not the thing, right? And osmotic demyelination we discussed. What is myasthenia gravis? Myasthenia gravis again. So myasthenia gravis is definitely there's a diurnal variation will be there. Diurnal variation. Okay. So that's also not the cause. The only thing is osmotic demyelination syndrome. Right now, what is the questions they're asking from this topic is what? How do you correct the hyponatremia in acute and chronic? Very, very important. The very, very important thing. Whenever there is acute hyponatremia, you should not correct very fast. When a chronic, you should not correct very fast. So they have given certain rates. Very important. In acute hyponatremia, you have to correct the sodium at a rate of just 8 to 12 milliequivalents per 24 hours. Okay, or maximum 18 milliequivalents in 48 hours. Very important. Okay, when you see hyponatremia patient, so when will you correct? So hyponatremia, to correct the patient should have some CNS manifestation like seizures or some altered sensorium or some comatose condition. Then you have to treat, and treatment also you have to go in a proper rate. You should not go at a very high rate. So because it leads to osmotic demyelination syndrome. So what is the guideline proposed rate is 8 to 12 milliequivalent 24 hours. But in the case of chronic, it's just only 4 to 6 milliequivalent to 24 hours. That much only you have to correct. You should not correct more than this. If you correct more than this, the patient will end up into osmotic demyelination syndrome. Right? Clear? Important. That's it. Right? Let us discuss about one more important question, that's SIADH. Very, very important thing. What is the vasopressin escape in SIADH refers to? First, what is SIADH? Okay. So let us see what is SIADH. Its name itself, syndrome of inappropriate ADH secretion. Right? That means ADH is secreted very, very inappropriately. So what I discussed, ADH is anti-diuretic hormone acting on the distal collecting duct and helps in reabsorption of the free water. Okay. In this syndrome, there is increased ADH secretion. Increased ADH secretion. Okay. So what is the stimulus for ADH secretion? We discussed serum osmolality is one stimulus. Okay. And decreased effective arterial blood volume is also one stimulus. So whenever the stimulus is there, then only ADH has to be secreted. Okay. But in this syndrome, without any stimulus, this ADH is keeping on getting secreted. So there is high levels of ADH. So now there's high levels of ADH, again, what is going to happen? As I discussed, this is your tubular epithelial cell. Again, this is your V2 receptor. Cyclic AMP is increased. Okay. And then aquaporin 2 has come and leads to what is called free water reabsorption. Okay. So just because ADH is increased, there's more and more and more amount of water is getting absorbed. Okay. So then because of this water content is increased, but not sodium content, the patient will develop hyponatremia. The patient develops hyponatremia. And this hyponatremia is called euvolemic hyponatremia. Very, very important. Why euvolemic hyponatremia? Because it is not associated with any volume loss, or it is not associated with any hypervolemic condition. Here the patient volume status is okay, but only because of free water reabsorption, his sodium content is decreased. That is called as euvolemic hyponatremia. So this is what is called SIADH. SIADH is syndrome of inappropriate anti-diuretic hormone secretion. There is increased ADH irrespective of your serum osmolality or anything. Because of ADH, there is more amount of water reabsorption that leads to hyponatremia. That is called as euvolemic hyponatremia. Okay. Now let us see what is going to happen. Right. So in SIADH, ADH is secreted. ADH is secreted irrespective of your osmolality. Irrespective of osmolality. So usually what should happen whenever the osmolality is increased, ADH has to increase. When osmolality comes to normal, ADH has to come down. But still, in this condition, even osmolality comes to normal, ADH won't come to normal. It's going on, increasing. That is what is called SIADH. So if it's going on increasing, what is going to happen? There is increased water reabsorption. Because of this, there is hyponatremia. The patient can develop some clinical manifestations. So because this hyponatremia is dangerous, so what our body is developed, that is what is called as vasopressin escape. Vasopressin escape. So this is our defense mechanism. It's a physiological mechanism which is developed by the kidneys. Okay, that is called vasopressin escape. So what is this thing? In syndrome of inappropriate ADH, because of ADH increased, there is free water reabsorption. Because of free water reabsorption, there is sodium can be decreased. This sodium decrease is lethal to the body. So because of that, our kidneys developed a mechanism which is a physiological mechanism. That is what is called as vasopressin escape. It is completely physiological. So name itself is vasopressin escape. Even though vasopressin is there in high quantities, our kidneys are escaping from its effect. That is called vasopressin escape. So how it is escaping is simple. Our kidneys, what they're doing in the case of distal collecting ducts, okay, they are decrease in the cyclic AMP production. Okay. So because decrease in cyclic AMP production, there is decrease in the aquaporin 2 channels. Aquaporin 2 channels. So there is no water reabsorption. So even though ADH is more, this ADH is acting on V2 receptors, but cyclic AMP is not getting produced. So no cyclic AMP, no aquaporin 2 channels, no free water reabsorption. So even though vasopressin is there, our body is getting escaped from its effect. That is what is called as vasopressin escape. Okay, that you see in case of SIADH, in the case of long-standing cases. Right? So this is what is asking, what is the question now? Vasopressin escape in SIADH refers to what? Decreased ADH secretion? No. In SIADH, there is always ADH secretion. Okay. And increased urine osmolality, it's not related to urine osmolality because when you are free water reabsorption, urine osmolality increase, but it's not related to any escape. Okay. Down regulation of V2 receptors in renal collecting. This is the correct option. Okay. Your V2 receptors are down regulated. Because V2 receptors are down regulated, there is no cyclic AMP. There is no aquaporin 2 channels. So even though ADH is there, but it's not unable to act on the V2 receptors because these receptors are down regulated. Okay, that is the correct option. And increased sodium is not the option. Clear? Simple thing. Right. So what new question they can ask is SIADH, it's syndrome of inappropriate ADH secretion. Because of inappropriate ADH secretion, increased ADH secretion, your free water is getting absorbed. So we'll have hyponatremia. To prevent this deleterious effects of hyponatremia, our kidneys has developed a mechanism that is called as vasopressin escape, which is a physiological mechanism. So what it is doing is it is down regulating the V2 receptors. How much ADH you produce? I won't show the V2 receptors. So it is blocking V2 receptors. So even though ADH is not there, it is not acting on the V2 receptors. There's no cyclic AMP, there's no aquaporin 2 channels, there is no free water reabsorption. So you're not getting any hyponatremia. Okay, so this is the vasopressin escape. It happens in the DCT. Its mainly thing is it will downregulate the V2 receptors because there's no V2 receptors, there's no harmful effects. Right? Important. There's one important thing I want to discuss in this thing. In SIADH, what is the drug of choice? You can see SIADH, you can give V2 receptor antagonist because ADH is there. You can give V2 receptor antagonist. The drugs are tolvaptan. Okay, oral drug is tolvaptan and IV drug is conivaptan. This is a new question they can ask you. Usually they will ask. Okay, SIADH, the drug of choice are vaptans, that is V2 receptor antagonist, tolvaptan, conivaptan. Right, clear? Right. Right. Let's go to next question. What is this question? Let us see this question. They're asking about insulin-like growth factor. Insulin-like growth factor 1 and insulin-like growth factor 2 share significant structural homology with insulin-related peptides. They have same homology with insulin-related peptides. Which of the best explains this similarity? Okay. Before going to the question, we just discuss about insulin-like growth factor. Right. So there are two things there. One is called as insulin-like growth factor 1 and insulin-like growth factor 2. Okay, the name itself indicates this is insulin-like growth factor. That means its structure is exactly similar to insulin. That is structure is similar to insulin. Okay, but they are functionally different. they are different. That is what's called insulin-like growth factor. Like means because they are always similar to the insulin in structure. That means they have two chains, that is chain A and chain B, and they have disulfide bonds. Okay, that is what's same insulin structure. Okay, that's the thing. So they're structurally similar. Then what is the difference functionally is very important. This insulin-like growth factor is produced by the liver. It is produced by the liver under the influence of growth hormone. Okay, once a growth hormone is there, then it will act on the liver to produce your insulin-like growth factor 1. So then it exerts its effects of growth hormone effects. Okay, this insulin-like growth factor 2 is produced in many tissues, and it is not growth hormone dependent, it's growth hormone independent. Okay, not because of growth hormone, because of some other things it produces. Right. This insulin-like growth factor 1 and 2, they act on insulin-like growth factor binding receptor. Insulin-like growth factor binding receptor. They cannot act on the insulin receptors. They can bind, but they cannot act on insulin receptors. Right, very important thing. So it just acts like a growth hormone. All the growth hormone actions like protein synthesis, okay, glycogenolysis, lipolysis, you're promoting the growth. All these things are done by this insulin-like growth factor 1 through the growth hormone. Right, simple. So insulin-like growth factor, it's just similar to insulin in structure, but functionally they are different. Insulin-like growth factor 1, very important. It is produced in the liver. It is stimulated by the growth hormone. So growth hormone exerts all its physiological effects through insulin-like growth factor 1. Right, simple. So they always bind to different receptors than not the insulin receptor. So let us see the options what they're saying here. So insulin-like growth factor 1 and 2 share significant structural homology with the insulin-related peptides, which of the following best explains the similarity? They're derived from the cleavage of circulating insulin. No, they are not derived from the insulin. Okay, insulin after cleavage, they are not getting derived. They're just coming from the liver or coming from different tissues. Okay, it's not related to insulin. They retain the C-peptide domains in the precursor molecules. As we discussed, they are structurally similar. Structurally similar means whatever insulin has, everything IGF-1 and 2 are having. So that's why they retain the C-peptide domain, correct? Okay, they're synthesized as pre-pro hormones, but lack A and B chains. No, I already told they have same structure as insulin. They have A chain, they have B chain, they have disulfide bonds, same structure, and they have identical receptor binding domains. No, they don't have any identical receptor binding domains. Insulin-like growth factor has an insulin growth binding receptor. Insulin has a different receptor. Okay, so because they are structurally similar, everything insulin have, these factors also will have. So that's why they retain the C-peptide domains in precursor molecules. Very important thing, right? In this explanation, this point is again very important. This insulin-like growth factor 1 is produced in the liver under the influence of growth hormone. That is a very important thing, right? Clear? Right. Let us go to the next question. Now, what is the question is saying? This 40-year-old male presents with enlargement of hands and feet. The male has come with enlargement of hands and feet, prognathism, that is this jaw enlargement, and newly diagnosed diabetes mellitus. So what is the examiner talking about? Enlargement of hands and feet, prognathism, and newly diabetes mellitus. It's all because of growth hormone excess. That is what is called as acromegaly. That's what's called acromegaly. Okay. Now serum IGF-1 is elevated. We discussed already because growth hormone exerts all its effects through the IGF-1. Serum IGF-1 is elevated. Yeah, it again shows your acromegaly. MRI shows pituitary macroadenoma. I discussed in pituitary adenoma, the most common is your prolactinoma, then non-functioning cells. Then after that, you have growth hormone secreting tumors also. Pituitary macroadenoma is there. So macroadenoma means more than 1 centimeter. Definitely you have to do surgery only. So, but surgery is deferred due to comorbidities. They cannot do the surgery. Now, what is the medical therapy in this patient? Right? Let us discuss this treatment first. Right? So let us see. Basically, growth hormone secreting tumors, that is your acromegaly. Right? If it is more than 1 centimeter, that is what is called as macroadenoma. Okay. Treatment of choice is always surgery. That surgery is transsphenoidal resection. You have to go transsphenoidally and you do resection. This is the first thing you have to do. But if any surgical comorbidities are there, then you can go for your medical management. So medical management, what you can do? You can decrease your growth hormone. How can you decrease growth hormones? One is your growth hormone receptor antagonist. Okay. Other is what is called as somatostatin analogs. Somatostatin analogs. You know, somatostatin is the one hormone which will inhibit all hormones. Okay. So there are two types of drugs which can act on the growth hormone excess acromegaly. One is growth hormone receptor antagonist. Other is somatostatin analogs. This growth hormone receptor antagonist is called as peglisomat. Okay. And somatostatin analogs are called as octreotide and pasiritide. Very important. Octreotide and pasiritide. So now what exam is asking? Any acromegaly is there growth hormone? Treatment of choice is always surgery. If you cannot do the surgery, what you can do? Medical management is there. For medical management, you have two drugs are there. One is growth hormone receptor antagonist, other is your somatostatin analogs. This antagonist is pegbisomant, other is octreotide and parathyroidism. Right? Let us see what is this thing. What is the question asking? So what are the regarding medical therapy? What is the patient? Octreotide reduces growth hormone secretion pituitary tumor. We discussed somatostatin analogs. This somatostatin will reduce everything, every hormone. So it reduces, correct? Then pegbisomant reduces IGF-1 levels without reducing tumor size. We discussed pegbisomant is growth hormone receptor antagonist. It also decreases the IGF-1 levels. It also okay. And second is pegbisomant acts by blocking growth hormone receptors. Yes, correct. This is also correct. And what is the wrong option here? Cabergoline is drug of choice in macroedema. What is cabergoline? Cabergoline is a dopamine agonist. Dopamine agonist. Okay. We are not using that thing. We are using drug of choice in the case of prolactinoma. It's a drug of choice in prolactinoma. It's not in the case of any other macroadenoma or any other acromegaly. Right. So that is the wrong answer here. Right. That is what they discussed. So 1, 2, and 4 are correct. That is what the question gave. 1, 2, 4 are correct. Clear? Simple. What we discussed in this thing, growth hormone acromegaly, very, very important thing. Patient will have enlarged feet and hands and prognathism, diabetes mellitus. You will diagnose by IGF-1 levels, that is your screening test. And then once diagnosed, you have to do the surgery. That is not surgery, you have medical therapy, growth hormone receptor antagonist, and octreotide, somatostatin analogs. Right? Right. Let us go to the next thing. See this thing, a 14-year-old boy, again 14-year-old boy, presents with rapid linear growth, rapidly he is growing, enlarged hands and feet, and 4 facial features. Again, rapid linear growth, enlarged hands and feet. Again, it's going towards your acromegaly. You're thinking growth hormone producing tumor. Right? So which of the following is most definitive test to confirm diagnosis? Very, very important, most definitive test. How will you confirm the diagnosis saying? Okay, so don't put IGF-1 levels. This IGF-1 is only screening test. It's only screening test. So if you're suspecting your growth hormone producing tumor, you have to see IGF-1 levels. If they're elevated, you are suspecting it. Then you can have to confirm the test. Okay. Random growth hormone levels, you cannot measure the growth hormone because it's a pulsatile release. Because it's a pulsatile, you cannot take the growth hormone levels in the blood. So it's a wrong option. Okay. Another thing is, this is important thing. Failure of growth hormone suppression after oral glucose. This is a very, very confirming test. So what you have to do, whenever you are suspecting acromegaly, you do IGF-1 levels. If they are elevated, then you have to do growth hormone suppression test. Okay. So what does growth hormone do? Growth hormone will always cause hyperglycemia. Okay. Will always increase blood glucose in the blood. So what we are doing, so we will give more glucose into the body, like some 50 grams of glucose will give. Then we'll see the growth hormone has to be suppressed. If it is not suppressing, that means even after you're giving some inhibitory stimulus, it is not suppressing. That means they has tumor. That's called acromegaly. Right? That's what we are discussing. So the main thing is when you're suspecting acromegaly, okay, always screening test. Screening test is serum insulin-like growth factor 1 levels. Because we discussed growth hormone always exerts its physiological effects through IGF-1 levels. Okay. Then to confirmation, what you are doing is this confirmation, we are giving glucose suppression test. The glucose suppression test. So why you're giving this thing? Usually increased glucose will suppress your growth hormone. Increased glucose will suppress your growth hormone. Okay. But when you are giving the glucose, if it is not suppressing, that means tumor is there in the body. So that's why you're doing glucose suppression test. That is what they decrease. So this option will decrease the failure of the growth hormone suppression after oral glucose. This is it. Right? Clear? Simple. So these are the important questions regarding the acromegaly. So simple things, patient comes in enlarged feet, prognathism, new onset diabetes mellitus, cardiomyopathy, then you're suspecting, do IGF-1 levels. If it is positive, go for the confirmation is always glucose loading test. Okay. After this test, if the growth hormone is not suppressed, you're confirmed as acromegaly. Then mainly you have to do for MRI brain to see the size of tumor. Then you have to go for surgery, that is a transperineal dissection. If surgery is not possible, medical therapy is two things are there. One is growth hormone receptor antagonist, that is a pegbisomant, and growth hormone receptor analogs, somatostatin analogs like octreotide and parathyroidism. Clear? This is clear? Right. So it's all about your growth hormone. Let us go for the other question. Right. We'll go to the next question. See, long-standing patient diabetic nephropathy. Already patient is there, he has diabetic nephropathy. Undergoes a renal biopsy. He undergoes renal biopsy. Which of the following findings is most strongly argue against the diagnosis? So what is asking is, what are the microscopic features in the case of diabetic nephropathy? Very, very important. Okay, so let us discuss about diabetic nephropathy. So what is going to happen here is in the diabetic nephropathy, because of high glucose levels, it is damaged the glomerulus. Okay, it is damaged the glomerular basement membrane. Once it damages the glomerular basement membrane, so what is going to happen? Slowly, proteins from the body will leak into the urine. That is what is called as albuminuria or microalbuminuria. And then slowly, all this glomerular mesangium will undergo sclerosis. That is what is happening in diabetic nephropathy. So this diabetic nephropathy, let us just increase this image once. Okay, right. So this diabetic nephropathy is always has a 5 stages. One is stage 1, stage 2, stage 3, stage 4, and stage 5. Okay, so stage 1 is hyperfiltration, stage 2 is silent, stage 3 is incipient, stage 4 is overt, and stage 5 is ESRT. So no need to discuss this thing. Let me discuss here. So you have to see three things. So what is happening in the microscopically, what is happening? Microscopically, what is happening? Okay, and clinically, what is happening? Clinically, what is happening? Okay. In the case of stage 1, what is going to happen microscopically? Nothing. It's just only glomerular hypertrophy will happen. Glomerular hypertrophy. Okay. So because glomerular hypertrophy is there, you will have hyperfiltration. So increased GFR, glomerular filtration rate. Okay. Then comes your second stage. In the second stage, what is going to happen? Your glomerular basement membrane is damaging. No, starting, damaging, thickening. Hyalinosis or thickening. Okay. Now your GFR is normal only. Okay. And the third stage is your mesangial sclerosis will have all this mesangial sclerosis. Then your albuminuria is starting. Okay. And then focal mesangial sclerosis and diffuse mesangial sclerosis. So here we'll have renal failure. Here we'll have end stage renal disease. Simple. This is a simple thing. So what is going to happen stage by step? One is glomerular basement membrane first undergoes hypertrophy. It leads to hyperfiltration. Then glomerular basement thickening and damage. Then leads to your GFR decreases there. Then your mesangial sclerosis, focal sclerosis, and diffuse sclerosis. So all these things leads to albuminuria and renal function. Right. So how will you diagnose your glomerular diabetic nephropathy? That is we have discussed diagnosing with using a condition called urinary albumin creatinine ratio, or you're just measuring your urinary albumin. Urinary albumin. Okay, it should be less than 30 milligrams per gram. This is a normal thing. Okay, if it is 30 to 300 milligrams per gram, that is what is called as microalbuminuria. Very important, very important. This is the first stage of diabetic nephropathy started. And if it is more than 300 micrograms per gram, this is overt albuminuria. It's already overt. With the patient development nephrotic syndrome, patient development end-stage renal disease also. Right? This is the thing. So this is what we discussed here. So this I want to show you here one important image. Right. Right. What is the thing? In this I discussed in the case of your stage 4, there is what is called as your focal mesangial sclerosis. If you see this thing, this part, focal part, this is sclerosed, and this is called as Kemmelstein-Wilson bodies. Very important potential question. So Kemmelstein-Wilson bodies, you see in case of diabetic nephropathy from the stage 4 onwards because of mesangial sclerosis. Right. Then let us see the questions here. What is the answer? A long-standing patient diabetic nephropathy undergoes renal biopsy. Which of the following findings would most strongly argue against the diagnosis? What will argue against diagnosis? One is diffuse mesangial matrix expansion with past positivity. Yes. Mesangial diffuse sclerosis can also happen. Uniform thickening of glomerular basement membrane under microscopy. Yes, this is the first initial change. This thickening of glomerular basement membrane and nodular glomerular sclerosis forming Kemmelstein-Wilson nodules. I discussed this is the stage 4 of diabetic nephropathy. And Harmony-Epstein changes involve tubular epithelial cells. See, the diabetic nephropathy never affects the tubules and all. It always affects your glomerulus. So this is the wrong answer. Okay. Now in INICET, what they'll ask is next exam they'll ask about Harmony-Epstein changes. Let us see what is this thing. So if you see this next image, if you see this image, so these are the renal tubules. So if it is divided as renal tubules, so you see all these tubules are enlarged. They're all enlarged. And if you see properly, there are small vacuoles. There are small vacuoles. There's nothing but your glycogen and all got accumulated in the tubules. So these vacuoles, when you stain in the past, they'll become as pink color. So that is what's called Harmony-Epstein change. You see in the case of diabetic emergency. You see in the case of diabetic emergency, like suddenly a patient is developing HHS or diabetic ketoacidosis. Okay, then all the high sugar levels because of osmotic change and all, that time they will damage the kidney and the tubules are enlarged and glycogen getting accumulated. That is what is called as Harmony-Epstein change. Harmony-Epstein change in renal tubular epithelium. This is the important thing. Okay. So today's option will be tomorrow's question. That is what I said. Okay. So in this they ask about only glomerular nephropathy. All the three things are glomerular things. Other things is only tubule thing. So because diabetic nephropathy chronically won't affect tubules and all, we eliminated this option. We selected these three options correct. Now, but I mentioned Harmony-Epstein change. This will be asked in the next question, next year question, right? So in diabetic emergencies, because of hyperglycemia, it causes damage to tubules. The tubules will be enlarged and glycogen is accumulated. It has past positivity. That is what is called as Harmony-Epstein change in tubular epithelial cells, right? Clear? Right. Very important. So diabetic nephropathy, what we studied, there are 5 stages are there. Very important thing. First is hyperfiltration, then normal filtration, then albuminuria, then renal failure and stage renal disease. How will you diagnose? Urinary albumin creatinine ratio less than 30 milligrams per gram is normal. 30 to 300 is microalbuminuria. More than 300 is your overt diabetic nephropathy. Right. One important thing I want to discuss here. Very important thing. We can discuss here. Okay. Okay. So next important question they can ask you is, what are the treatment of choice for diabetic nephropathy? Drug of choice for diabetic nephropathy. There are only three drugs. Three drugs are there. One is your ACE inhibitors or ARBs. That is your telmisartan or your enalapril, ramipril. These are the first line drugs. And second thing is your SGLT2 inhibitors. Very, very important. SGLT2 inhibitors. Okay, that is your dapagliflozin, canagliflozin. And third is your finerenone. This is a potential question. This is a new question. Finerenone. Okay, this is a mineral corticoid receptor antagonist. These are the only three drugs which are approved for the diabetic nephropathy. If any patient of diabetes, if he develops diabetic nephropathy, is your if he's showing some 24 urinary albumin creatinine ratio as some more than 30 milligrams per gram, please start one of these drugs: ACE inhibitors or ARBs, SGLT inhibitors, and finerenone. These are the only three drugs which are approved for your diabetic nephropathy. Right? Clear? Let's go to the next question. Right. So 38-year-old woman on long-term glucocorticoid therapy. Already patient is on long-term steroid therapy. There is a clue. Presence with weight gain is a weight gain. Moon faces, okay, and dorsocervical fat pad and violation striae. So you know under what exam is talking about? Yes, it's about Cushing syndrome. This is about what's called Cushing syndrome. Right? Okay. Then her blood pressure is elevated. Yes, because of Cushing blood pressure is elevated. Which of the following is the most appropriate initial test to confirm hypercortisolism? Very, very important thing. So how will you confirm cortisol test? Hypercortisolism. Let us discuss that thing. So these are the image I'm showing. This is purple striae. This can be image based question. They can ask this purple striae and all. Violation striae. These are the striae marks. They can ask. They can show in the exam. So just here they kept only directly questions like patient has violation striae and all. Next time they can put you the image based also. Right? Okay. So let us see how to diagnose and all. So whenever you're thinking of suspecting your Cushing, whenever you're suspecting some Cushing disease, Cushing syndrome, that means patient has a weight gain, patient has diabetes mellitus, patient has some central obesity, patient has biliary striae, you are thinking of some Cushing syndrome. The first thing you have to do is rule out iatrogenic cause. Rule out iatrogenic cause. So what is iatrogenic cause means? That means if patient is taking some steroids, that is the most common cause. So you have to stop the steroids. Okay, if it's not taking iatrogenic cause is not there, then you have to think whether really cortisol is elevated or not. So what you have to do is you have to screen for the cortisol. Okay, you have to do serum cortisol levels. So what you can do 24 hours urinary cortisol, 24 hours urinary cortisol. Okay, or you can do midnight salivary cortisol test. Midnight salivary cortisol test. Okay. If in this test, if cortisol is elevated, yes, oh, I'm thinking of Cushing syndrome. I'll just see the cortisol levels randomly, 24 hours urinary cortisol I can see, or midnight salivary cortisol I will see, or early morning cortisol I will see. If it's elevated, yes, cortisol is elevated. Yes, there is a hypercortisol means that. Okay. Now I need to know whether this hypercortisolism is Cushing syndrome or not, whether it's because of tumor or not. So to confirm what I can do for confirmation. Okay, so for confirmation what I am going what is called as low dose dexamethasone suppression test. Low dose dexamethasone suppression test. So what I'm giving here, I'm giving low dose of dexamethasone. If I give low dose of dexamethasone, what it will do, dexamethasone exerts inhibitory effect on the pituitary gland. So there is no corticotropin releasing hormone, there is no ACTH, there is no steroid. Normal persons. If you give dexamethasone to me, so dexamethasone exerts inhibitory effect on the pituitary, so there is no ACTH, there is no steroid. But this patient, because he's having some Cushing syndrome, even though you give dexamethasone, even though you suppress your pituitary gland with dexamethasone, still his cortisol levels are high. If these cortisol levels are high, that confirms your Cushing syndrome. Clear? Right? This is the thing important. Right? Right. Right? Clear? So let me again explain to you people. So for example, if you're suspecting any Cushing syndrome, so first what you're doing is salivary cortisol, 24 hours urinary salivary cortisol, 24 hours urinary cortisol or midnight salivary cortisol. This is, it's like a screening test. Okay. In this, if cortisol is elevated, what I will do is I'll do low dose dexamethasone suppression test. Dexamethasone suppression test. So what I will do, low dose dexamethasone I'll give, and I will see whether cortisol is suppressed or not. If then also if cortisol is elevated, then I can say it's a Cushing syndrome. Okay. Once its Cushing syndrome is done, then I will check for ACTH levels. Okay. If ACTH is elevated, if it's elevated, okay, that means it is pituitary source, that is ACTH dependent Cushing syndrome. That means pituitary gland is producing more amount of ACTH. That is why we are having steroids. If ACTH is normal or low, then I can think ACTH independent. That is your adrenal gland is secreting the thing. That means your adrenal adenoma or anything. Simple. This is the simple flowchart. Okay. The first thing is, this is the important thing. Whenever you are thinking this is to screening, you screen the patient with 24 hours urinary cortisol or midnight salivary cortisol. If cortisol is elevated, yes, you go for the DEXA suppression test. That is your confirmation. Once in this also, if cortisol is elevated, yes, that is Cushing syndrome. Now you check for the ACTH levels. If it's elevated, it's ACTH dependent. That is your pituitary cause. If ACTH is normal or decreased, it is ACTH independent. That is your adrenal cause. Right. So let us come to the question. What is he asking now? Right. So, which is appropriate test to confirm the hypercortisolism? What is appropriate test now? It's not plasma SIADH measurement. This is not the thing, because it helps to know whether hypercortisol is because of adrenal gland or pituitary. It is not the thing. Serum cortisol is random cortisol. It's to screen. It's just to screen hypercortisolism, not any Cushing syndrome. And overnight low dose dexamethasone suppression. Yes, this is to confirm your hypercortisolism Cushing syndrome. And then MRI pituitary gland, it's just imaging. It's not a thing. Right? So answer is your overnight suppression of low dose dexamethasone suppression test. Yeah, right. So let's go to the next question. Right, simple thing. Let us come to the next question. A 24-year-old woman with type 1 diabetes, okay, 24 years type 1 diabetes, presents with vomiting, abdominal pain, altered sensorium. He has given a question. Type 1 diabetes, vomiting, abdominal pain, altered sensorium. Yes, definitely it's a diabetic ketoacidosis. It's a medical emergency. On examination, is dehydrated. Yes, because of more sugars, more glucosuria, more dehydration. Yes, with a deep labored breathing. What is the breathing called? Kussmaul's respiration. Very important. Why this Kussmaul's respiration? Because of your metabolic acidosis. Right. Now, what are the things he gave? Blood glucose 320 milligrams as expected, high sugars. Arterial pH is 7.1. Yes, it is acidosis. Okay. Serum bicarbonate is 10 millicontent. Yes, it is metabolic acidosis. And potassium is 5.6. Now, what is asking examiner? Which of the following parameters is not used as diagnostic criteria for a condition? Right. Now, how will you diagnose DKA? Very simple. To diagnose DKA, the name itself says diabetic ketoacidosis. You need to have RBS as high values, that is sugars are increased and ketone bodies are elevated, and acidosis should be there. Only three things are there. We are not seeing any other thing to diagnose as a diabetic ketoacidosis. Sugars are high, ketone bodies are elevated, and then your acidosis is there. Then you can label it as diabetic ketoacidosis. You don't need to see any other things. Right? Let us see this thing. So what are the options? Arterial pH less than 7.3. Yes, acidosis. We can diagnose it. We can use for diagnosis of DKA. Serum bicarbonate less than 15 millicontent. Yes, we can label it as DKA. Elevated blood glucose. Yes, you can use to diagnose DKA. But serum potassium level, you are not using in the diagnosis of diabetic ketoacidosis. So it is not at all involved. So the option is serum potassium level. But serum potassium level, very, very important. It helps to monitor the patient of diabetic ketoacidosis. Monitor DKA. What is the important calculate abnormality you have to monitor in DKA? That is serum potassium level. See, today's option is tomorrow's question. So now they'll ask this serum potassium, they kept in the option. Next question, they will ask question like, when you're treating the management, when you're managing the patient with diabetic ketoacidosis, what calculate abnormality you have to monitor? Potassium, very, very important. Why potassium? So because when you're treating diabetic ketoacidosis, you are giving insulin, right? So what this insulin is doing? This insulin helps to decrease blood glucose levels. Apart from this, insulin always tries to pull the potassium from the blood into the cell. Okay, so from the blood into the cell, this is your blood levels. So from the blood, it enters the cell because of the insulin. Okay, then there is profound hypokalemia. Then there is to profound hypokalemia. So that is the reason when you're managing a patient with diabetic ketoacidosis, you always have to monitor potassium levels. And if potassium levels are less, that is less than 5, okay, you are start giving potassium chloride injection in your treatment. Very, very important because your insulin will reduce potassium. So even though it's reducing potassium, when it is low, I will supplement the potassium. Clear? That is simple. Now, few points regarding this diabetic ketoacidosis, very, very important points. So very standard points. Okay. In DK1, you need to remember is there should be two requisites for forming a DK. One is absolute insulin deficiency. Absolute insulin deficiency. Absolute insulin deficiency. So the patient should have absolute insulin deficiency. Whenever there is absolute insulin deficiency, then only there is more sugars are elevated, right? So that's why you always see in the case of type 1 diabetes mellitus, who is not taking insulin. So non-compliance is a very, very common cause of your diabetic ketoacidosis. And second prerequisite is excess counter-regulatory hormones. Excess counter-regulatory hormones like glucagon. Hormones like glucagon. So when will this counter-regulatory hormones increase? Whenever there is a stress reaction like infections, like pneumonia or UTI, and then infarctions like myocardial infarction or acute coronary syndrome or maybe your acute ischemic stroke. In these conditions, because of glucagon, you will have increased ketone bodies. So absolute insulin deficiency leads to hyperglycemia and excess counter-regulatory hormones like glucagon leads to increased ketone bodies. So these two are prerequisites for developing of DKA. Very, very important. Right? So in this, what is the simple question they're asking? What is the most common cause of DKA is non-compliance. Non-compliance to medication. There is no insulin. The patient will have absolute insulin deficiency. The patient will end up into DKA. And what is the other important causes? Infections like pneumonia is very, very important cause because of stress, glucagon, it promotes ketone body stimulation and leads to what is called as your diabetic ketoacidosis. So what are the clinical features as I discussed? The mainly patient will be dehydrated, very, very important. Because of dehydration, the patient will have abdominal pain, nausea, and vomiting. This is only triads they'll give. Abdominal pain, nausea, vomiting, and altered sensorium, small breathing, all these things they'll give. Okay. And one important thing I have to say is ketone bodies here. Okay. The three ketone bodies, acetone, acetoacetate, and beta hydroxybutyrate. Beta hydroxybutyrate. Okay. Very, very important thing I'm saying. These two, acetone and acetoacetate, can be seen in the urine. Okay. And this beta hydroxybutyrate is present in the serum. It will never come in the urine. Very, very important. Now the question they're asking is, what is the most specific for all these things? The most specific is beta hydroxybutyrate. Very, very important. Okay, very important question. But acetone and acetoacetate, these are not specific, but these are the screening things you are helpful for diagnosing the things. We are not doing beta hydroxybutyrate regularly in the clinical practice. In the clinical practice, you are checking urine acetone and urine acetoacetate. So what the question they're asking is, if the patient is having urine ketones positive, what ketone body it is? It is acetone or acetoacetate. It is not a beta hydroxybutyrate, never, because beta hydroxybutyrate never forms in the urine, never comes to the urine. And second question they can ask is, what is the most specific ketone body is beta hydroxybutyrate, right? Very important thing. But it's always seen in the serum. You can see, you'll never see in the urine. Clear, right? Then what is the diagnosis? I discussed already. RBS is high. Yes, clear. Ketone bodies, urine ketone bodies are positive, right? And ABG is showing AGMA, high anion gap metabolic acidosis. Very important. It's not an AGMA, it's AGMA. Because of ketone bodies, you'll have high anion gap metabolic acidosis, right? Then treatment, I discussed always fluids is the first treatment, because these diabetic ketoacidosis patients are always in a fluid deficit of almost 9 liters. Okay, if you calculate, there will be 9 liters fluid deficit. You have to give that thing. And second thing is IV insulin. This is the only indication you have to give IV insulin. That is almost 0.1 unit per kg stat, then followed by 0.1 unit per kg per hour. This is the infusion you have to give insulin. Okay, and then if potassium is less, you have to give potassium also, KCl. And one more important thing, what is the indication of giving bicarbonate? Normally, you won't give bicarbonate in DK patients. You will give bicarbonate only when pH is less than 7 or bicarb is less than 5. Very, very important. Okay, this is a potential question. If pH is less than 7, if bicarb is less than 5, then only you are giving soda bicarbonate. Otherwise, soda bicarbonate is not routinely recommended in DKA, because if you correct the ketone bodies, H dose will be corrected, bicarb will be become normal. Unless bicarbonate pH is less than 7 and bicarbonate less than 5, you are not going to give soda bicarbonate in treatment of DKA. Only treatment is fluids and insulin. If potassium is low, replace potassium. If bicarb is less than 5 or pH is less than 7, give soda bicarb. Clear? Right? So what DKA? Don't miss DKA. DKA is the one which is very, very important in your exams. Okay, it's a medical emergency because every intern must know. That's why they will ask about DKA in need PG or anything. Okay, clear. Right. Let us come to the next question. A 40-year-old woman presents with persistent dry mouth. What is persistent dry mouth? What is it called as? It's called as xerostomia. Okay, persistent dry mouth, xerostomia. And also foreign body sensation in the eyes. That's called gritty sensation in the eyes. Okay, this is what important. Xerostomia they gave. Laboratory evaluation reveals normal anion gap metabolic acidosis with hypokalemia. That is NAGMA with hypokalemia. What does it indicate? It always indicates renal tubular acidosis. Very, very important. NAGMA is always because of renal tubular acidosis. On examination, there is bilateral enlargement of parotid glands. Now you understand what is the diagnosis now. Okay, already dry mouth, dry eyes, NAGMA, and also bilateral parotid enlargement. So what is the diagnosis? This always is Sjogren syndrome. You know, Sjogren syndrome. What is the Sjogren syndrome? What is the thing? It's an autoimmune disorder. There is a lymphocytic infiltration of your all exocrine glands. That is your ocular glands, your oral glands, and parotid glands. All these things. Because of the thing, they'll develop what is called dry mouth, xerostomia, and dry eyes is called as keratoconjunctivitis sicca. Keratoconjunctivitis sicca, dry eyes, and then parotid gland enlargement. Okay, and affects renal tubules. Mainly, they will cause what is called as distal renal tubular acidosis. So all these four they have given. Xerostomia is there, foreign body sensation eyes because of your dry eyes, and NAGMA because of renal tubular acidosis and parotid enlargement. It's a Sjogren syndrome. Now, which of the following is the most appropriate investigative to conduct the diagnosis? Right, let us see. Serum ACE levels. No, we are not doing serum ACE levels because it helps to diagnose sarcoidosis. Okay, so we are not dealing with sarcoidosis, we are dealing with Sjogren syndrome. Therapeutic trial of glucocorticoids. Without diagnosing, you won't give glucocorticoids. Okay, we are not some quacks, we are some physicians, right? And shimmer test with SSA and anti-rolla antibodies. Very important. This is the most specific diagnostic test, right? And cellular and scintigraphy we are not doing. So option is shimmer test with autoantibody measurement. Right, clear? Let us discuss some points on Sjogren syndrome. As I discussed, it's always autoimmune condition. It's always autoimmune condition. Okay, affecting your glands lead to xerostomia, keratoconjunctivitis sicca, okay, and parotid gland enlargement, and distal renal tubular acidosis. Very, very important. Okay, so how will you diagnose? For xerostomia, you cannot diagnose anything. For keratoconjunctivitis sicca, you can do what is called a Schimmer's test. What is Schimmer's test? You are putting some paper in the lower eyelid and checking the teardrops, how much it is coming. If it is less than 5 mm, that's usually 5 to 10 mm, or every person will soak that paper. If it is less than 5 mm, it is diagnostic of dry eyes. Right? And parotid gland enlargement, okay, if you do biopsy, you'll see lymphocytic infiltration and distal renal tubular acidosis. That's also very, very common. Right? So how will you diagnose? Diagnose only antibodies are there. Very important. Anti-O antibodies, anti-La antibodies. Very important. Right? So before this thing, let me discuss about one or few more antibodies. You know, actually in autoimmune disease, ANA is a very commonly used diagnostic antibody, but it's only just most commonly used. It's only for the screening. It's not helping diagnose anything. Right? And then comes anti-double strand DNA. Okay, anti-double strand DNA, especially specific for SLE, very important. And again, anti-Smith antibody. Anti-Smith antibody also very specific for the SLE. Right? And anti-Rolla antibody. It is specific for your Sjogren syndrome. Very important. And anti-U1 RNP. It's specific for your mixed connective tissue disorder. Very important. And then anti-RNA-P, RNA polymerase. It's for the psychotic manifestations in autoimmune diseases. Right? Very important things. Very important. And last important, anti-histone antibodies. It is in drug-induced SLE. Drug-induced SLE. These are the important antibodies you have to know. Definitely. Drug-induced SLE. Right? ANA is the most common help screening. And anti-double strand, anti-Smith is specific for the SLE. Anti-Rolla for the Sjogren syndrome. U1 RNP is for mixed connective tissue disorder. Anti-RNAP for psychiatric manifestations. And anti-histone antibodies are the drug-induced SLE. Clear? Right? This part is clear. We'll go to the next question. So what is this question dealing with? A 45-year-old woman with rheumatoid arthritis has persistent disease activity in spite of methotrexate therapy. They gave methotrexate. Even then also disease activity is there. She started a novel drug that suppresses inflammation by modifying gene expression without altering DNA sequence. So nothing is there, leading to reduced cytokine production. So what they're saying is they started on a drug which is reducing the inflammation, but it is not modifying the gene expression, okay, without altering the gene expression. It's not altering the gene expression. For example, this is your DNA. This is your DNA. It's producing one gene. Okay. So this gene expression is not altered, but effects are suppressed. That means it is not affecting the gene. It is affecting the process after the transcription or process apart from this DNA. So what is that mechanism? It's just simple only. You just need to remember it is inhibition of histone deacetylase. That is epigenetic mechanism. Epigenetic mechanism. There's nothing to explain in this thing. So here what is it saying is they developed a drug. The drug is not acting on the genetic material. It's not altering the DNA sequence. It is just right. It is just modifying the gene expression without altering genetic material. That means it is doing epigenetic mechanism. Your epigenetic is histone acetylation, methylation, all these things. Your option is histone acetylation. Right? Nothing to explain. Just simple. Right. Let us come to the next question. It's a 28-year-old patient presents a deep rapid breathing. That is again a Kussmaul breathing, deep rapid breathing, Kussmaul breathing. Okay, ABG shows pH 7.2. Yes, pH 7.2 is a acidosis. Acidosis, right? Correct. And PaCO2 is 20. Okay, and bicarb is 8. Bicarb is 8 is what? It's a metabolic acidosis. Okay, and sodium is 136, chloride is 108. Which of the following is acid-base disorder? So what you have to do is first you have to calculate whenever you see metabolic acidosis, you have to calculate anion gap. So what is anion formula? Sodium minus chloride plus bicarbonate. Simple. If you calculate sodium is 136, chloride is some 108 plus 8, that is 116. That is here 20. So if anion gap is 20, if it is more than or equal to 10, it is high anion gap. Simple. So high anion gap metabolic acidosis. So pure high anion gap metabolic acidosis with appropriate respiratory compensation. Simple thing. Right. So let me discuss about ABG. Whenever you see the ABG questions in the exam, what you have to do is first you see the pH. Okay. If pH is less than 7.3, yes, it is acidosis. You confirm. Right. Then you see PCO2 and bicarbonate. PCO2 and bicarbonate. If PCO2 is low, that means it is respiratory alkalosis. If bicarbonate is low, that is it is metabolic acidosis. Okay. Now you will see this pH is correlating with which primary event. This is pH is less than 7 acidosis, bicarb less metabolic. These two are correlating. So primary event is primary metabolic acidosis. Simple thing. Okay. Once you ascertain there is a metabolic acidosis, then you know which type of acidosis you have to calculate anion gap. What is anion gap? Sodium minus chloride plus bicarbonate. Okay. 8 to 10, 8 to 12 is normal. If more than 12 is high anion gap, metabolic acidosis. If less than 12 is your normal anion gap metabolic acidosis. Simple. Okay. Then if metabolic acidosis, you will see the compensation. For the compensation, the Winter's formula is there. That formula not required. If you they ask us the equation, then you can do. Otherwise, just at least you have to identify whether it's a metabolic acidosis or respiratory acidosis. If metabolic acidosis, Hagma or none. That is what the question is. Right? You have to calculate anion gap. What is the anion gap formula? Is very clear. Right. Let us go to the next question. A patient with primary hyperaldosteronism present with resistant hypertension. Right? Okay. Which of the following findings will be least consistent with this diagnosis? So what is saying about primary hyperaldosteronism? So what will happen in primary hyperaldosteronism? So what is the functions of aldosterone? So let us see. Let us see the RAS system. So whenever there is decreased blood pressure, whenever there is decreased blood pressure, or whenever there is decreased blood volume, whenever the decreased blood volume, whenever decreased sodium, okay, whenever decreased blood pressure or decreased blood volume or decreased sodium, our kidneys, JG cells will secrete what? Renin. JG cells will be stimulated and produce what is called as renin. We already know. Okay. Now this renin acts on what is called as it converts angiotensinogen to angiotensinogen to angiotensin 1. Very important. This angiotensinogen is produced from the liver. Very important question. Okay. Now this angiotensin 1, okay, it's converted to angiotensin 2 by action of enzyme called angiotensin converting enzyme. This enzyme is present in the lung, much more important. Okay. Now this angiotensin 2 produces three actions. One is it causes your renal efferent vasoconstriction. Efferent vasoconstriction. Okay. Very important. Renal glomerulus, afferent arteriole, glomerulus, efferent arteriole. It acts on the efferent blood vessels and causes efferent vasoconstriction. And this angiotensin 2 stimulates your sympathetic nervous system. Sympathetic nervous system. And this angiotensin 2 helps to produce your aldosterone. Right? Okay. Very important. Okay. Now, what this aldosterone is doing very important. Let me discuss this thing. Right. So now what this aldosterone is doing, this aldosterone mainly acts in your collecting duct. Aldosterone, it acts on your collecting duct. Yeah, it acts on your yeah collecting duct. Okay. If you see the collecting duct, there are three cells are there. One is principal cells, alpha intercalated cells, and beta intercalated cells. Very important. Okay. In the principal cells, what is it doing? Let us see. Okay. Now this is aldosterone. This is a lumen. Okay. These are the principal cells. So what is going on here? Here, this aldosterone will act on the mineralocorticoid receptor, which is a nuclear receptor. Very important. It acts on the mineralocorticoid receptor. Once this mineralocorticoid receptor happen, that leads to formation of epithelial sodium channels, ENaC, epithelial sodium channels, that leads to help in absorption of the sodium. Simple. This aldosterone acts on the mineralocorticoid receptor that leads to formation of epithelial sodium channels, helps in absorption of sodium. Okay. It also helps in excretion of the potassium. Excretion of potassium. Simple. So sodium reabsorption and potassium excretion. This is the main function of aldosterone. And now in the intercalated cells, what is it doing in the intercalated cells? This aldosterone, okay, it will stimulate your carbonic anhydrase. So leads to what's called H2O plus CO2 becomes bicarbonate, H2CO3, and breaks into H plus and HCO3 minus. So H plus will be excreted, HCO3 is absorbed. So HCO3 are taking because of this thing, it leads to what's called metabolic alkalosis. This is the only place in the kidney where bicarbonate is generated, and aldosterone is the only hormone which helps in generation of bicarbonate. So it leads to metabolic alkalosis. Right? Simple. Beta intercalations we'll discuss later. Right? So now the trio: sodium reabsorption, potassium excretion, metabolic alkalosis. This is the function of aldosterone. So this aldosterone leads to sodium reabsorption, potassium excretion, and metabolic alkalosis. We discussed. So what are the simple questions they'll ask in this thing is aldosterone will act in the collecting duct. First question. This acts through a mineralocorticoid receptor, which is a nuclear receptor. That's second question. And this receptor helps in formation of ENaC, epithelial sodium channels. It helps in sodium reabsorption, potassium excretion, and metabolic alkalosis. Metabolic alkalosis by action of alpha intercalated cells. The sodium potassium action is through principal cells. These two are important. Right? Clear? Now let us see what is the question answer here. So which of the following findings will be least consistent with diagnosis? If patient is having more aldosterone, what will happen? So if more aldosterone is there, suppressed plasma renin activity. Yes, because already this see here this renin because of renin increase only aldosterone is increased. If aldosterone is more, because of negative feedback mechanism, your renin activity can be decreased. Yes, correct option, that is hypokalemia, metabolic alkalosis. Yes, we know. We already discussed sodium reabsorption, potassium excretion, metabolic alkalosis. So this is there. Increased sodium reabsorption is sodium reabsorption without edema, correct. And marked hypernatremia with hypervolemia. This is wrong. There's never be hypervolemia because it is not like ADH. ADH is free water reabsorption. This is not causing any free water reabsorption. So there is no hypervolemia. So this is a wrong option. Clear? Right. So very important thing. These are the few questions you'll ask in hyperaldosteronism. Okay, let us go to the next question. A 55-year-old man with septic shock is resuscitated with large volumes of intravenous fluids. Okay, septic shock, you're giving more fluids. After 24 hours, he develops worsening metabolic acidosis. Okay, then they did ABG. It shows 7.32. Yes, 7.32 is slightly acidotic. Bicarb is 16. Yes, metabolic acidosis is there. Serum electrolyte sodium 140 and chloride is 118. Usually chloride value should be some 90 to 100. Okay, it's 118 is more chloride is there. So which of the following is intravenous fluids is most likely responsible for acid disturbance? So what is the examiner talking about? It is called hyperchloremic metabolic acidosis. Hyperchloremic metabolic acidosis. Let's discuss this thing. So what this thing is hyperchloremic metabolic acidosis. If you give to any patient of more amount of sodium chloride, more amount of chloride is there, and this chloride is causing metabolic acidosis, and that is called as hyperchloremic metabolic acidosis. Now, how this sodium chloride is causing metabolic acidosis? Let us see in this image. This is what I'm discussing, the type 2 intercalated cell. Okay, type B intercalated cell as I discussed it. Okay. This is your lumen. This is your blood. Okay. So whenever you give patient of more amount of sodium chloride, all the sodium chloride is coming and going into the glomerulus and coming to renal tubules. Now the sodium chloride is coming to renal tubules. So more amount of chloride is there, more amount of chloride is there. So all this chloride is going, what is going to happen in the type B intercalated cell? One pump will activate, it's called chloride bicarbonate exchanger. Now this chloride is getting absorbed because there's more chloride, chloride is getting absorbed in the exchange of bicarbonate. So bicarbonate is going out. So alkali is going out. You will develop acidosis. That is what is called as hyperchloremic metabolic acidosis. Usually in normal individuals, this pump is inactive, but when you give any individual more amount of fluid, so because of more chloride content, this chloride content is going into the urine, and now our pediatric says that chloride bicarbonate pump is activated, has an absorption of chloride in exchange of bicarbonate. So bicarbonate is losing, you are developing metabolic acidosis. So that is what is called as hyperchloremic metabolic acidosis. So in which conditions you will see? Usually when you do resuscitation with NS alone, more amount of sodium chloride you are giving, then you will see this thing. Usually in the case of DK patient, for example, DK patient, he developed HACMA. After seeing, because of HACMA, you are giving more amount of fluids, and you hydrate in the patient. But suddenly patient metabolic acidosis, anion gap is closed. But here, hyperchloremic metabolic acidosis is developed. Then what you have to do? You have to stop the 0.9% NS. You can give other fluids like RL you can give, or you can give your 0.45% NS. Okay, you can decrease the concentration, give the NS. Right? Simple. This is what the question is saying. So this is the question is about hyperchloremic metabolic acidosis. pH is 7.3, yes, acidosis. Sodium bicarbonate 16 and pH is 108. So it is hyperchloremic metabolic acidosis. So what is the which of the following IV fluid is responsible for this condition? I said already normal saline because it contains sodium chloride. That's one it is responsible. Dextrose no chloride, ringer lactate no chloride. This is also no chloride. Right? Clear? Okay. Okay. So let us go to the next question. Right. So 32-year-old woman presents with fatigue and recurrent renal stones. Again, the comes fatigue and recurrent renal stones. Why recurrent renal stones? That means because of increased calcium levels. Investigation will pH 7.2, pH is 7.2. Yes, it's acidosis accepted. Bicarb is 12. Okay, it is correlating the primary event. It's a metabolic acidosis. That is also accepted. Okay, sodium 134, chloride 113, potassium is 2.8. Potassium is 2.8. I discussed already hypokalemia and metabolic acidosis. Always your renal tubular acidosis. Okay. Now what is asking whether it's type 1 or type 2 or type 4 or HAGMA. Okay. Let us see renal tubular acidosis. So renal tubular acidosis, actually the three types are there. One is type 1 renal tubular acidosis, type 2 renal tubular acidosis, and type 4 renal tubular acidosis. Right. So type 1 renal tubular acidosis, it's because of the distal coronary tubule. Type 1 is because of your proximal coronary tubule, and type 4 also mainly because of your distal coronary tubule. Okay. In type 1, when distal is the problem. If distal is problem means why there is acidosis? If the distal coronary tubule is problem, in the intercalated cells, there is no generation of bicarbonate. There is no bicarbonate generation. That's why patient develops metabolic acidosis. In proximal, proximal bicarbonate is getting reabsorbed. So there is no reabsorption of bicarbonate. That's why patient develops metabolic acidosis. In both the conditions, potassium will be low. In both the conditions, potassium is low. But in case of type 4, potassium is high. That is a very important critical. Hyperkalemic metabolic acidosis, very important thing. Right? Simple. And in the case of distal, I always say in the distal, what is going to happen is H plus is getting excreted, bicarb is getting reabsorbed. If H plus is not getting excreted, what will happen? All this H plus will go, and act on the bone. Okay, and this bone will take H plus and release the calcium. H plus calcium exchange. Okay, so what is going to happen in distal RTA? In distal RTA, so H plus is not getting excreted, so H plus is getting accumulated. Now this H plus will go to the bone, it takes the calcium as buffer, it takes out the calcium, and H plus is taken into the bone. Right? So that's why they'll have more calcium and they have nephrocalcinosis. They have nephrocalcinosis. Okay. But in the case of proximal, if proximal is gone, what is it? Everything is getting reabsorbed proximal only. Your glucosuria, so hypoglycemia, amino aciduria, hypocalcemia, hypophosphatemia, everything is getting absorbed in the PCT only. So if PCT is gone, all these things will be reduced. Simply. Right? And type 4, I discussed only hyperkalemic acidosis. You can see only with NSAIDs, or in case of diabetes mellitus, or in the case of ACE inhibitors. These are the only three conditions where you can see type 4 renal tubular acidosis. Simple. Right? So now let us see the question what is saying. So what is the most likely diagnosis here? Already fatigue and recurrent renal stones means increased calcium. So increased calcium is seen always Distal only, we discussed this distal only, right? So distal is the correct answer, right? Proximal, you won't see increased calcium. The hypocalcemia is there, hypophosphatemia is there, hepatocyturia is there. This is called Fanconi syndrome. And type 4, you will say hyperkalemia. They have hypokalemia, so it's not the answer. Hagma, it's not about Hagma, right? Clear, right? So let's go to the next question. Right. Right, next question. A 40-year-old man with hypertension has recurrent episodes of nephrolithiasis. Here, the patient is having nephrolithiasis. That means renal stones are there. Imaging shows multiple calcium-containing renal calculi. Which of the following drugs would be most appropriate for long-term management? Very important thing. Here, the exam is asking about loop diuretic or thiazide diuretic. Okay, let us discuss this thing. So, what is the thing is loop diuretic and thiazide diuretic? So, loop diuretic acts on sodium, potassium, 2-chloride pump, which is present in the thick ascending limb, and thiazide acts on the sodium chloride pump, which is present in the TCT. That much is here. Okay, so when this loop diuretic acts on sodium potassium 2-chloride pump, your sodium is decreased, yes. Your potassium is decreased, yes. Your chloride is also decreased, right? Okay, and then what is happening here? There is calcium and magnesium is also getting decreased. Calcium, magnesium also getting decreased. But in the case of thiazide diuretic, what is going to happen here? Your sodium is decreased, right? Your chloride is decreased. But what is going to happen here? There is calcium is absorbed. Calcium is absorbed with the thiazide. Why and all the concept you can discuss. I already discussed in the previous classes, the proper classes. In the thiazide diuretics, when you use sodium chloride pump is inhibited. When our sodium chloride pump is inhibited, sodium is not getting absorbed. And sodium is not getting absorbed. The cell requires sodium. So it takes sodium from the blood in the exchange of calcium. So calcium is getting absorbed more. So therefore, urinary calcium is less. Urinary calcium is less. So that is why it's a drug of choice for the nephrocalcinosis, right? So it's a drug of choice for renal stones. Any patient of hypertension which is having some renal stones, you have to go for thiazide diuretic. That's what we discussed here. Patient is nephrolithiasis, is containing calcium renal calculi. So even though hypertension it is there, so how will you treat the patient is asking. So spironolactone, it's a potassium sparing diuretic. It is nowhere related to calcium metabolism. Hydrochlorothiazide, yes, it's a thiazide diuretic because it's inhibiting sodium potassium pump. So there is decreased urinary calcium, increased absorption of calcium. So decreased urinary calcium, it decreases the urinary calcium and then decreases the stones. Very important. Ethacrenic acid and furosemide, these two are loop diuretics. They increase urinary calcium. Very important. Right? Simple thing. I am discussing one simple thing. Loop diuretic versus thiazide diuretic. Very, very important thing is in loop diuretic, urine calcium is more. In thiazide diuretic, urine calcium is less. The same thing, loop diuretic is also called as Bartter syndrome, same Bartter phenotype. Thiazide is also called gentleman phenotype. Very important. Gentleman phenotype. Okay. So only urine calcium is the one which can differentiate both Bartter and gentleman or loop diuretic. Urine calcium is always low in the case of thiazide diuretic. That makes it a drug of choice for the patient who is having recurrent renal stones with hypertension. Right. Right. Next question. We'll wind up fast already because of the screen and it took some time. Right. Any doubts you can ask, otherwise you can wind up fast. Just a minute, 1 minute. Right. Let's go to the next question. So what is the question? A 42-year-old woman presents with symmetrical small joint pain and prolonged morning stiffness. What is this symmetrical small joint pain? It's again rheumatoid arthritis. It's a prolonged morning stiffness. Yes, it's inflammatory arthritis. Serology is positive for anti-citrulline and anti-CCP. Anti-cyclic citrulline positive. Again, confirmatory rheumatoid arthritis. So joint biopsy most likely shows which are the following. So what is asking is in rheumatoid arthritis, what is the pathology? Very, very important thing. In rheumatoid arthritis, the pathology is always synovial inflammation. Synovial inflammation. This is the only disease where there is synovial inflammation. So first of all, acutely synovial inflammation will happen. All the inflammatory cells will come. The synovial inflammation become thicker and forms a layer. And that layer is called as pannus. That layer is called pannus. Very, very important. So in NEET question, they're asking what is the pannus? Is synovial hyperfiltration. So in synovial layer hyperplasia and inflammatory cell infiltrate, forming a pannus thick layer. That's called pannus. Okay. So this is called hyperplastic synovium with invasive granulation tissue around the cartilage. Right. Articular cartilage degeneration, marginal osteophyte is all about osteoporosis. Subepidermal blistering with linear IG deposition, it's not this thing. And granular symptoms and noise. Only thing is synovial hyperplasia, synovial inflammation leading to pannus formation. So this is the image I will show you here. So this is the thing, cartilage, and this part is what is called as pannus. If you see here, slowly there is synovial proliferation, synovial hyperplasia, and all these small dots are the inflammatory cells present in the synovium. So that's what's called pannus. It's again a potential question. They can ask an image-based question. Right? Clear? Right. Next question. Right. Let us see come a patient with progressive skin tightening, and digital ulcers. Again done. Progressive skin tightening is sclerosis of the skin. Okay. Digital ulcers. Okay. Small ulcers is found to have ANA positivity. Okay. Further testing reveals anti-topoisins and antibodies. Which of the following complications most strongly? What is the question asking? Progressive skin tightening is sclerosis. Digital ulcers again. You'll have Raynaud's phenomenon. So examiner is talking about your systemic sclerosis. Okay. So 1 or 2 points regarding systemic sclerosis, very important. In the case of systemic sclerosis, you will have two types. One is your limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. Very important type. Okay. So what is happening in limited cutaneous systemic sclerosis? Actually, it involves limitedly only just a distal parts of the hands, face is involved. It's involved diffusely, entirely your hands, face, your thorax, trunk, abdomen, everything is involved in case of diffuse systemic sclerosis. Okay. In limited cutaneous, Raynaud's phenomenon is present. After so many years, then you'll have skin manifestations. But in diffuse, your Raynaud's phenomenon plus skin manifestations, they come simultaneously, almost simultaneously. Very important thing. Okay. Then in limited cutaneous, your crust is common. What is crust? Calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. All these things are present in limited cutaneous. They are offset in diffuse cutaneous. And rest everything is there in diffuse cutaneous. For example, your renal crisis is not there in limited, it's present in the diffuse cutaneous. Okay. In the case of lungs, okay, pulmonary artery hypertension is the manifestation of limited cutaneous. ILD is the manifestation of diffuse cutaneous. Very important. Very important. Right? Now, next comes antibodies. When you see antibodies, this limited cutaneous has anti-centromere antibodies. Okay. And this as anti-topoisomerase antibodies or anti-RNA polymerase antibodies. Simple. That's it. These are the 5 points you need to know. Limited is only limitedly involved. It's diffuse involved. Raynaud's phenomenon, skin manifestation, save so much time is there, but actually they present simultaneously in diffuse cutaneous. Crust is present in limited cutaneous. It's also in diffuse cutaneous. Renal crisis is present in diffuse cutaneous. In the case of lungs, ILD is there in diffuse. pH is there in the limited cutaneous. Very important point. This is very important point. Examiners always confuse this thing. And then anti-centromere antibody position in limited cutaneous and anti-topoisomerase and RNA polymerase present in diffuse cutaneous systemic sclerosis. Right. So let us see what is the thing he's saying. So which are the following? His progressive skin lesions as sclerosis. Distal ulcers is Raynaud's phenomenon. ANA positive is autoimmune disease. Further testing reveals anti-topoisomerase. That means what is discussing about? Diffuse cutaneous systemic sclerosis. Diffuse cutaneous sclerosis, not about limited cutaneous. Which of the following complications most strongly associated with the antibody? Yes, interstitial lung fibrosis. Yes, correct only. And then limited cutaneous, no, it is seen in case of limited cutaneous. Predominant esophageal dysmotility, no, it is seen in limited cutaneous. Crust is common in limited cutaneous. Telangiectasia, crust, again limited cutaneous. So answer is interstitial lung disease. Clear? Very simple. Let us go to the next question. So all of the following are true about crust syndrome. Crust again you see in case of limited cutaneous systemic sclerosis. So what are all the following is asking. Let us see. Raynaud's phenomenon is often the earliest manifestation. Raynaud's phenomenon. Yeah, okay, it comes. We already discussed in limited cutaneous. Raynaud's phenomenon will come and then come after many years. Then you have skin manifestations. So it can be earliest manifestation true only. And then anti-centromere antibodies commonly present. We discussed limited cutaneous. You have anti-centromere antibodies and diffuse cutaneous you have anti-topoisomerase antibodies. And facial skin involvement can occur. Yes, in limited also facial skin involvement can occur, but trunk abdomen you see in case of diffuse cutaneous. And pulmonary artery hypertension may occur independently of interstitial lung disease. I discussed in the lungs, limited cutaneous have pulmonary artery hypertension, and diffuse will have interstitial lung disease. Yes, this is also correct. Anti-topoisomerase antibodies characteristically isolated. No, anti-topoisomerase in case of diffuse cutaneous systemic sclerosis. So this is the wrong answer. Right, clear, done. Next question, we'll go to the next question. A 25-year-old woman develops episodic distal ischemia episodically. See, this is very important question. Episodic distal ischemia. Sometimes is developing distal ischemia on cold exposure. Characterized by color change followed by reactive hyperemia. So which of the following are established cause of this condition? So what is discussing about? It is nothing but the Raynaud's phenomenon. It is discussing about Raynaud's phenomenon. So what is Raynaud's phenomenon? On exposure to cold environment, okay, there is what is called as vasoconstriction of the vessels. Okay, there is what is vasoconstriction of vessels. Once there is vasoconstriction of vessels, that leads to what is called as hypoxia to the tissues. Again, there is immediately circulation is restored. That's called hyperemia. Okay, so because of vasoconstriction, patient will develop pallor. Because of hypoxia, patient will develop cyanosis, blue color. And because hyperemia, because patient will again redness. So this is what is called as Raynaud's phenomenon. It's always intermittent. It occurs mainly because of the cold exposure. Once they get exposed to cold environment, so what is going to happen? Suddenly vasoconstriction results will happen. So patient will develop pallor. The fingers will become pallor. And because of hypoxia, is there cyanosis, blue color. And again hyperemia, there is red color. This is called mnemonic is PCR. This is the sequence of colors you see in case of Raynaud's phenomenon. Okay, so which are the following established cause of this condition is saying? That means it's mainly because of vasoconstriction. You have to see what are the all the drugs, all the things, secondary things which can cause vasoconstriction. Let us see. Sumatriptan, we know it's a 5-HT, 1B, 1D agonist. Used in case of migraine. Migraine pathology is because of your vasodilation. So you are doing vasoconstriction. It's again vasoconstrictor. Yes, it's a vasoconstrictor. Yes, it can cause Raynaud's phenomenon. Systemic sclerosis. Sclerosis, again, all the vessels vasoconstriction, it can cause Raynaud's phenomenon, correct? Cryoglobulinemia, because of cryoglobulinemia, they can block the vessels, vasoconstriction, yes, they can lead to this thing. And hyperthyroidism is not at all involved in the case of this thing. So answer is, which of the following are established? 1, 2, and 3 are established things. Clear? Right. Let us discuss a few points about Raynaud's phenomenon. So Raynaud's has two types. One is called primary, other is called as secondary. Okay. Secondary is called phenomenon. Primary is called as a disease. Okay. As I discussed, patient will have vasoconstriction, then have hypoxia, then have hyperemia. Okay. Because of vasoconstriction, there is a pallor. Because of hypoxia, there is a cyanosis. Because of hyperemia, there is a redness. That is called as a pallor, cyanosis, redness. PCR. Very important thing. Okay. Right. So primary means what? Primary means it is not associated with any other. It's a primary thing. It's basically it's a genetic thing. Patient will have family history definitely. Okay, but patient don't have any ANA positivity or no other drugs are not there. Nothing is not there. These are not there. Just directly primary it came. In the case of secondary, either patient will have drug history or patient will have ANA positivity. It's there, but there's no family history. That is the secondary thing. Family history is not. That's it. Simple. So they'll ask about primary phenomenon, secondary phenomenon. Primary is secondary phenomenon. Secondary will not have family history. They'll have some autoimmune history like ANA positivity or some drug history will be there. Primary will have family history. Simple thing. So as discussed, one more thing they're asking is what are the color change sequence? Pallor, cyanosis, and redness. PCR, white, blue, and red. Very important thing. Any drugs which can cause vasoconstriction, any condition which vasoconstriction leads to Raynaud's phenomenon. So that's why systemic sclerosis, your cryoglobulinemia, your 5-HT, 1B, 1D agonist, triptans, all these are causes of Raynaud's phenomenon. So what is the treatment of choice? Treatment of choice is actually calcium channel blockers you can give because they are vasodilators. Okay, right. Clear? We'll go to the next question. Right. So match the following crystallized arthropathy. This is nothing much it's to discuss. This is only memory point. We'll discuss this thing. Right. So what is about the gout? We already know gout always causes a hyperuricemia, uric crystals. All these crystals are your negatively birefringent crystals. Where the option is a strong negative birefringent and first metatarsal phalangoid is involved. You know, the simple thing. And pseudo gout again, it's a weak positive birefringent, but it's calcium and they have chondrocalcinosis. Very, very important thing. Pseudo gout has a chondrocalcinosis. Right? If you take the knee joint here, they have that cartilage will be calcified here. That chondrocalcinosis is in X-ray. Okay. And then these two things are important. Calcium oxalate deposit is because of your needle-shaped crystals in calcium oxalate crystals. And hydroxyapatite is because of your distilled shoulder. It's nothing to explain. Just to you have to see what is gout, what is pseudo gout. Especially important point is pseudo gout is called chondrocalcinosis, which is very, very important. They can ask repeatedly in this thing. In X-ray also they can show any chondrocalcinosis there. You can identify the pseudo. Right. Next question will go. Right. A 45-year-old man with chronic alcoholism is a chronic alcoholism. Presence of the muscle weakness and tremors. He has a muscle weakness and tremors. Laboratory evaluation hypomagnesemia. Magnesium is low. Okay, this is the magnesium is low. Which of the following is the primary regulator of serum magnesium? So what is asking is which of the mechanism is regulating the magnesium in the body? Right? For you see the magnesium, for the magnesium, how the magnesium is getting into the body through the GI tract. Okay, through GI tract, especially in the case of jejunum and ileum. Jejunum and ileum. it's getting absorbed. Okay. Again, in the kidneys, very important. In the kidneys, we know already in the Bartter syndrome we studied, along with the calcium, magnesium also getting absorbed. So in the kidneys, almost 5% or 5% getting absorbed from the PCT, about 60% from the thick ascending limb of loop of Henle, and 20% from the DCT. Okay. So these two are because of your paracellular transport. We discussed your paracellular transport. Okay, so how magnesium is present in the body? It's mainly because of absorption from the GIT or absorption from the kidneys. In the kidneys, 5% from the PCT, 60% from thick ascending limb, and 20% from the TCT. Okay, so the main regulator of magnesium in the body is the kidney, because all this, every PCT, thick ascending, DCT, everything is absorbing. So the main regulator of the magnesium is kidney. That's what I'm asking. The primary regulator of serum magnesium is, it's not dietary magnesium intake, it is not intestinal absorption of magnesium, it is not with the bone. It's mainly because of the renal tubular absorption of magnesium. Okay. So both thick ascending limb is involved and also DCT is involved in the absorption. Right? Clear? Simple question. Nothing to discuss. You got next question then? Right. A 45-year-old male presents episodic headache, palpitations, and sweating. What is this syndrome? Episodic headache, palpitations, and sweating. This is called as pheospell. Pheospell. What is pheospell? In pheochromocytoma, what is happening here? In pheochromocytoma, intermittently catecholamines are getting released. Once catecholamines are released, they're sympathetic. You will have headache, you will have flushing, you have sweating, and all these things are there. So that's called as pheochromocytoma. So blood pressure 190/100. Imaging reveals an adrenal mass. You see this thing imaging here, right? So this is your liver. This is the liver. Okay. This is your kidney. Okay. And this kidney's mass. This is your adrenal mass. This is your adrenal mass. Okay. Right. It reveals an adrenal mass. So what is the question is asking? What is the best initial biochemical screening test? Right. So first of all, what is pheochromocytoma? Pheochromocytoma is mainly because of increased adrenal tumor, adrenal medullary gland tumor, adrenal medullary tumor, producing what? Catecholamines, more amount of catecholamines. So because of catecholamines, there's increased norepinephrine, increased epinephrine, all these things are increased. Okay, so they'll have sympathetic symptoms, manifestations, especially they'll have headache, they'll have high BP, okay, they'll have palpitations, and they're sweating, sympathetic cholinergic is sweating. All these things are there, and all these things you can say is pheospell. So how will you diagnose? You have to diagnose using you have to diagnose the catecholamines. You cannot diagnose the catecholamines. In the catecholamine derivatives are metanephrines, okay, metanephrines. Okay, of those metanephrines, urine or plasma are very specific. Okay, serum metanephrines are very, very important for diagnosing of your pheochromocytoma. Very important. Okay, and for localizing the gland, you will do for MIBG scan. Very important thing. This pheochromocytoma. That's it. So adrenal medullary tumor producing catecholamines. So norepinephrine, epinephrine produced. So you'll have headache, increased BP, palpitations, and sweating. This is what is called as a pheospell. Okay, diagnosed using metanephrines, and this metanephrines or plasma metanephrines are very, very important thing. Okay, and you can localize MIBG scan. So what is the question you asked? What is the best initial clinical test? Initial biochemical screening test. Plasma catecholamines, you don't use plasma catecholamines, you use derivatives metanephrines. MRI abdomen, you are not using MRI abdomen, right? And plasma free metanephrines, correct? And 24 hours urinary fraction, no, right? The most specific is serum metanephrines. That's the thing. If they ask to localize the gland, it's MIBG scan. Very good. Right? Let's go to the next question. This question will deal in the last. At the end, we'll discuss this question. Right? Just remind me. We'll discuss in the last. Right? So all of the following, this question we discussed already. Secondary hyperparathyroidism, also secondary prime. Parathyroidinoma is the primary thing. Right? We discussed this in the first question. Right? Right. Regarding cause of bilateral pitting pedal, which of the following are correct? So for any patient to have bilateral pitting edema, what are the mechanisms are there? So right, for example, pitting edema from the blood vessel, the blood has to go to the interstitium. So how will it go? Three mechanisms. One is increased hydrostatic pressure. If there is increased hydrostatic pressure, then more blood will come into the blood vessel to the interstitium. And second is decreased oncotic pressure. That means what? Whenever there is decreased oncotic pressure, the decreased osmolarity from low to high, blood will come into the interstitium. When will the decreased oncotic pressure is there? Whenever there is decreased protein. When protein content is decreased, your osmolarity decreased, your oncotic pressure decreased. So there is thing. And third is increased capillary permeability. If there is any capillary damage, then blood will leak from the blood vessel to the interstitium. So these are the only three mechanisms which can cause edema. One is increased hydrostatic pressure, decreased oncotic pressure, or increased capillary permeability. Now, based on these causes, different things is asking. Let us see the options. INICET is always about seeing the options and ruling out other options, right? First thing, regarding cause of bilateral pitting pedal, which of the following are correct? Chronic venous insufficiency is the most common cause in elderly. Yes, elderly people, they have so many venous insufficiency, varicose veins. It will lead to one of the causes for pedal edema. Yes, correct option. Congestive heart failure causes edema due to increased capillary hydrostatic pressure. Yes, because of congestive heart failure, more blood is there in the blood vessels, increased hydrostatic pressure, so it leads to edema. Correct only. And cirrhosis leads to edema by a decreased plasma cirrhosis. Because of cirrhosis, liver is which is synthesizing albumin, no albumin, because no albumin, low oncotic pressure, from low to high, blood goes into causing edema. It is also correct. And lupus nephritis is common cause of isolated bipedal edema. Lupus nephritis is common cause of bipedal. How is it possible? It's not a possible. It is a bipedal edema cause. One of the causes lupus nephritis, but it's not the most common cause, right? And renal cause involves protein loss with secondary RAS activation. Yes, when I was renal cause there, this protein loss is there. I discussed already. There is an increased RAS activation, sodium reabsorption. It leads to edema. Yes, correct. Right? Simple thing. So when I was edema is there, okay, it can be because of the cardiac, or it can be because of the renal, or it can be because of your liver. Important things. So cardiac and all because of increased hydrostatic pressure, renal and all because of your again same increased hydrostatic pressure because of your more fluid overload, liver because of decreased albumin and decreased oncotic pressure. Very important thing. Right? Apart from this, local causes are very important. What are the local causes? In elderly person, varicose veins, venous insufficiency, very important. Unilateral, it is especially DVT, very important thing, or lymphedema is also another important thing. Right? So these are different mechanisms of causing your bilateral pitting pedal edema. Right. Next. An 18-year-old from Rajasthan is diagnosed with mixed plasmodium vivax and plasma plasma. Now the patient is having vivax and malaria, both are there. What is the appropriate treatment day 2 of therapy? Very, very important thing, right? So let me discuss this thing. So one example did malaria. Okay. See if it's a vivax or a falciparum. It's a vivax or a falciparum. If it's a vivax, the treatment is always chloroquine 25 mg per kg for 3 days. That is the first treatment. Okay. Plus along with this, you have to give primaquine 0.25 mg per kg for 14 days. This is the treatment standard malaria vivax treatment. Okay. If it is a falciparum, if it is uncomplicated, not complicated. We'll see what is complicated. Complicated, simple thing, you have to give IV artesunate, nothing else. If it's uncomplicated, you have to give artesunate combination therapy. Okay. So what does artesunate combination therapy contains? It contains artesunate plus sulfadoxime plus pyrimethamine. Very important. Sulfadoxime, pyrimethamine. Okay. It's a 3 days therapy. It's a 3 days therapy. Okay. Along with this, you have to give primaquine on only second day. Very important dose. Primaquine, here the dose is 0.75 mg per kg on day 2. Very important. Very important. Very important. Okay. You have to give artesunate combination therapy for 3 days. On the day 2, you can give primaquine, that is 0.75 mg per kg. Only single day. In vivax, it is 0.2 mg per kg for 14 days. Right? Clear? Right. So now let us see this artesunate combination therapy. When you see here artesunate combination therapy, when you see the artesunate combination therapy, it contains 3 days, day 1, day 2, and day 3. Okay. Day 1 contains artesunate plus sulfadoxime, pyrimethamine. Okay. Only that's 1 day only. Day 2 artesunate, day 3 artesunate. That's it. That's it. That kit contains only these things. 3 days artesunate, 1 day is artesunate plus sulfadoxime, pyrimethamine, and this sulfadoxime is given on day 1. Okay. Along with this thing, in the day 2, you are adding primaquine. You are adding primaquine. That is 0.75 mg per kg. Right? Clear? That's it. Simple. Okay. So if the patient is coming to vivax and falciparum malaria, what you will do? You have to give falciparum malaria treatment because artesunate can act against the vivax also, but chloroquine cannot act against the falciparum. So that's what the question is here. But your options is correct. It's wrong only. Don't follow this question. Please follow this chart. Okay. So as the question, what is the thing? It's containing both vivax and falciparum. So you treat like falciparum only. What is the appropriate day 2 of therapy? So you have to give artesunate combination therapy. So artesunate combination day 1. day 2 and day 3. Day 1 contains artesunate plus sulfadoxine pyrimethamine. Okay. And day 2 contains only artesunate, day 3 also only artesunate. Along with this thing, in day 2 you can give primacin. So option is should be artesunate plus primacin. This is the option. The answer here is wrong. Don't follow this question. Okay. This is wrong. This is wrong. So the answer is wrong. Right? Clear? Right. So don't forget, please, every time they can ask you this. Right. So please don't forget, whenever the malaria comes, it's Vivax or falciparum. It's a Vivax. Definitely you have to give chloroquine and primacin. Chloroquine 25 mg per kg for 3 days and primacin 0.25 mg per kg for 14 days. Very, very important thing. Okay. So 0.25 mg per kg means it's almost 1/4 of 60 kg, 15 mg. Okay. If it's a falciparum, it's complicated, you have to go for IV artesunate. Very important. It is uncomplicated oral artesunate combination therapy. It contains 3 days of drugs. First day, second day, third day. First day contains artesunate plus sulfadoxine pyrimethamine. Second day contains only artesunate. Third day also only artesunate. In the second day, you have to add primacin only 0.75 mg per kg on day 2. Only single dose. Right? That's very important. Then comes this thing, a 40-year male presents high-grade fever, right? Altered sensorium is diagnosed severe plasmodium falciparum, again severe malaria, right? During the course of illness, he develops hypoglycemia, metabolic acidosis, acute kidney injury, respiratory distress, chest extrusion, bilateral diffuse infiltrates, echocardiogram, normal left ventricular function. All of the following are recognized features of severe falciparum malaria, except, right? So, exam is asking about when will you say it's a severe falciparum malaria? Okay, so I discussed already. So malaria has uncomplicated and complicated. If you see the complicated, that means he's having some organ damage is there. Like for example, hemolytic anemia. It's a complication. Patient is having thrombocytopenia, complication. Patient is having acute kidney injury. Patient is having acute liver injury. Patient is in comatose or altered sensorium. Patient is having hypoglycemia. All these things are complication. And patient has what is called as acute lung injury, also called as ARDS, due to what is called as non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema. That means because of the plasmodium vivax only, it is causing damage to the endothelium that leads to pulmonary edema. That is non-cardiogenic. It is not because of the increased failed heart or pulmonary edema. It is because of non-cardiogenic pulmonary edema. That is called ARDS. You are diagnosed by PaO2 by FiO2 ratio less than 300. And chest X-ray showing some bilateral infiltrates. Okay, it's not about cardiogenic pulmonary edema. So that's what the question is asking about. So all the following are possible in the case of malaria, severe malaria. Hypoglycemia, yes, because liver failure is there, hypoglycemia is possible. Lactic acid because of liver failure, lactic is possible. Acute kidney injury possible. Cardiogenic pulmonary is not possible here because it will cause what's called ARDS. It means cause non-cardiogenic pulmonary edema. This is because of malaria parasite itself damage to the pulmonary endothelium that leads to what's called non-cardiogenic pulmonary edema. And also here the examiner has given one important question. Echocardiogram reveals normal left ventricular function. Okay, if left ventricular function is normal, how will the patient have cardiogenic pulmonary edema? So that's why INICET questions are very, very common sense questions. Right? Simple. So you have to study about what are the complications of the malaria. So whenever this is a complicated malaria, what is the treatment of choice? Excellent. Every time it's only IV artesunate. It's always IV artesunate. Never go for artesunate combination therapy. Now don't give for any drugs, oral drugs. You have to give IV artesunate. Right? Okay, clear. Next question. Patient with HIV and TLD regimen is started on rifampicin-based DDT. What is the appropriate modification? Very, very important, right? So let's discuss about HIV treatment and doses or not. So HIV, whenever there's there, you have to give TLD. Very, very, very important. Now, this NACO guidelines, National AIDS Control Organ Guidelines, has made it completely simple. Before, like nothing. Once if patient is diagnosed with AIDS, treat the patient. Treat the patient. All patients are same drugs: tenofovir, lamivudine, and dolutegravir. Okay, this is 300 mg. Very important. This is 300 mg. This is 50 mg. Okay, you have to give only single tablet, fixed dose tablet. That's every morning they will take. Okay, this is the thing for everything. This is for treatment also. And for prophylaxis, for example, what examiner asks is prophylaxis. For example, an intern is taking blood and he has got stuck with the HIV positive patient. So now he has to take prophylaxis. What is the regimen? Again, the regimen is TLD regimen. Again, 300, 350 mg. But he has to start within 2 hours. Its maximum benefit is when it starts in 2 hours until maximum is 72 hours. Within 3 days he has to take, but if he takes within 2 hours, it's very beneficial. Right? Simple. The next question is asking is when our TB is there. What is the problem with the TB here? In the TB, we are using a drug called rifampicin. So what is the rifampicin drug? The rifampicin is an enzyme inducer. Enzyme inducer. Okay. If it's enzyme inducer, here what is the problem here? You have tenofovir. Tenofovir is your NRTI. Lamivudine is your NRTI. Then dolutegravir is your integrase inhibitor. Your dolutegravir is integrase inhibitor. Okay. It is metabolized by CYP3A for metabolism. So because rifampicin enzyme inducer, it will induce this enzyme. So dolutegravir is getting metabolized fast. It's getting metabolized fast. So decrease the efficacy. Decrease the efficacy. So what will you do in this condition? That is what exam is asking. So when you use the patient, when patient is having TB and also HIV together, when you are taking HIV drugs and is taking TB drugs also, because TB has a rifampicin, because it is enzyme inducer, it will induce a CYP3A4 enzyme. This is the enzyme which metabolizes the dolutegravir. So dolutegravir efficacy is decreasing. So what will you do? So what will you do? You can increase the dose of dolutegravir. So increase such a condition, you have to increase the dolutegravir. So usually taking 50 mg, you can give 50 mg BD. So that's what the question is asking here. So a patient with HIV and TL regimen started on rifampicin based ATT. What is the appropriate modification? No change. No, because already rifampicin is metabolizing this dolutegravir. So its efficacy is decreasing. You have to change it. Add dolutegravir 50 mg twice. Yes, this is the question. Patient will take TLD single tablet in the morning plus again dolutegravir 50 mg in the night. Simple thing. Right? Stop dolutegravir. No. Stop tenofovir. Regular nothing. Right, clear, simple thing. Very important, very potential question. So HIV patients, don't forget every time TLD 300, 350 prophylaxis treatment, whatever it is TLD is, nothing else has changed. Okay. If patient is taking ATD, anti-diabetic drugs, because rifampicin is there, rifampicin is enzyme inducer. It is a induced CYP3A4 enzyme which will metabolize dolutegravir. So dolutegravir efficacy will reduce. You have to increase the dose of dolutegravir. You can increase one extra dose in the evening. Right, clear. Next. A 34-year HIV patient presents with multiple opportunistic infections over time. Match each organism with the most appropriate combination of CD4 threshold. So one important thing you have to remember here. Right. So based on CD4 count, your opportunistic infections are different infections are there. Let us see. If CD4 count is less than 200, so mainly you will get what is called pneumocystic pneumonia, candidiasis. Very important. This table is very important. Candidiasis and progressive multifocal leukocytosis because of your JC virus. Okay. If CD4 is less than 100, you will get toxoplasmosis. Okay. And what is called as a cryptococcus. Okay. If CD4 less than 50, you will get what is called Mycobacterium avium complex, and you will get what is called as your cytomegalovirus. That's it. These three things you should remember. You should remember definitely. TB can occur at any CD4 count. So it's not about CD4 count and all. But these three things are very important. If CD4 count is less than 200, you get pneumocystic gyrus pneumonia and candidiasis and progressive multiple leukocytosis. If less than 100, toxoplasmosis, cryptococcus, and less than 50 is Mycobacterium avium complex and cytomegalovirus. Right. So let us see. So what is the questions is asking here? First one, if CD4 is less than 50, you will get periventral hemorrhage retinitis. That is CMV retinitis. Correct only. Okay. When CMV is there, cytomegalovirus, you have to treat with ganciclovir or valganciclovir is correct only. This is okay. If CD4 less than 100, multiple drink enhancing lesions in basal ganglia. Multiple drink enhancing in case of toxoplasmosis. Yes, CD400 is toxoplasmosis. When toxoplasmosis, you treat with sulfadizine and pyrimethamine. Very good. Correct. And CD4 less than 200, progressive dyspnea with markedly AA gradient, diffuse ground-glass infection. This is your pneumocystic pneumonia. You are treated with only Septron, that is trimethoprim sulfamethoxyl. Correct. If CD4 less than 100, markedly raised dopamine expression LP, Indian ink positive, right? This Indian ink positive is cryptococcus. Yes, CD4 less than 100, we have toxoplasma and cryptococcus. Correct. You are treated with amphotericin and flucytosine. Correct. All the options are correct. Right? Simple. That's the thing. Answer. Answer is A1, B2, C3, D4. Everything is correct. Right? Clear? Okay. Simple thing. I'm discussing again here. So if CD4 is less than 200, you will have pneumocystic pneumonia. In pneumocystic pneumonia, definitely you will have acute respiratory distress syndrome only. Number of infiltrates are there. A gradient is decreased. HRCD has so many infiltrates are there. You are treated with only Septron, that is trimethoprim sulfatase. Okay. And then if CD4 count is less than 100, you have toxoplasmosis and cryptococcus. Toxoplasmosis will have multiple ring enhanced lesions. Cryptococcus will have Indian stain positive. You have to give amphotericin and flucytosine. This is sulfidized and all. Okay, and still less than 50, you'll have cytomegalovirus, definitely gancyclone or valgancyclone, or you'll have Mycobacterium avium complex also. Simple. Just study this bit, very important thing. Definitely they'll ask. And this chart is very, very important. This chart, what I given is very, very important. Okay. Don't forget this chart. Right. We'll go to the next question. A 40-year-old man with end-stage renal disease has been on maintenance hemodialysis for 12 years. For 12 years, he's on dialysis. Okay, now what is happening? He presents progressive pain and stiffness in shoulders and hands. Yes, some progressive pain in shoulders and hands. Imaging shows cystic bone lesions. Cystic bone lesions are there. Okay, and biopsy shows extracellular deposition of amyloid. Some amyloid is there that stains positive for the Congo red and shows apple green bifurcations under polarized line. So, which of the following is the most likely precursor protein responsible for this deposition? So what he's asking is, if a patient is CKD patient, if unexpectedly develops amyloidosis, so what is the most common precursor protein is asking? Okay, normally what is the precursor in amyloidosis and all? Amyloidosis depends upon the different proteins are there, like transthyretin, all these things are there. But in the case of CKD, who is on dialysis, who is on maintenance hemodialysis, what is going to happen is, there is one protein called as, there's one beta to microglobulin, which is not dialyzable, Because it is not dialyzable, it gets accumulated and forms abnormal protein and forms an amyloid. So if CKD patient develops any amyloidosis, it is not because of some normal protein like immunoglobulin light chain or any amyloid A protein. It's mainly because of beta to microglobulin, because it is non-dialyzable and will be keep on accumulating in the body. Right? This is answer. Clear? Nothing simple. Next important, very, very important thing. Hepatitis B curve image is given. A patient recovered from hepatitis B, which of the following curve represents the antibody seen 4 weeks post recovery. So let us see this thing. Right. So study this thing, very important. So whenever patient is having some acute hepatitis B infection, what is going to happen? Suddenly, if I get some hepatitis B, so hepatitis B surface antigen has come into my body. So this blue color is hepatitis B surface antigen. It will come and then it subsides in some 3 months. Okay. Immediately after hepatitis B surface antigen has come, our body will mount an immune response. So your hepatitis B C antibody will develop. Okay. In these two types of IgM and IgG, IgM is orange will come down and then IgG will be present in the body throughout life. And once hepatitis B surface antigen has come down, then your anti-HBs is started increasing. Okay. Simple. So let me discuss this thing here. So one is called hepatitis B surface antigen. Okay, it denotes infection. If hepatitis B surface antigen is present, it indicates infection. You are infected. Okay, if it is present, it indicates infection. Okay, simple. Apart from that, we have what is called hepatitis B C antigen. C indicates cellular. It is present in the cell only. It won't come into the serum. So in the serum markers, you will never see hepatitis B C antigen. But our body will develop immune response to it. It will develop antibody. One is IgM antibody, indicates acute infection, and IgG antibody indicates your chronic infection. And then comes hepatitis B E antigen, and E indicates your replicative potential. If that means replicative potential, it usually correlates with the acute infection. If it's there, means it's acute infection and its replicative potential, high viral load is there. And last, you will check for the hepatitis B virus DNA. You will check for the DNA count, PCR will check, and how many BNT copies of hepatitis virus are there. Right? Simple. If hepatitis surface antigen is infection is there. If hepatitis B C antigen is not there in the serum, antibodies IgM is acute, IgG is chronic. Hepatitis B antigen is replicative potential. Hepatitis B viral is similar PCR technique. And last is anti-HBs. That means hepatitis B surface antigen. It means patient has recovered. I got infection, I got recovered, but antibodies are left there in the body. Or patient has a post-vaccination. Nothing is there, only just if I get vaccinated, then there is also chance of anti-HBs development. Is there? Because vaccination, you are giving only hepatitis B surface antigen to the body, so your body will develop anti-hepatitis S antibodies. Clear? Right. Now let us see what is the question is asking. Hepatitis B curve image given. A patient recovered from hepatitis B. Which of the following curve represent the antibodies seen 4 weeks post-recovery? Post-recovery, what is this thing? Always anti-hepatitis B surface antibody. So what are the options here? Anti-hepatitis IgM, it indicates acute. It is not post-recovery. Okay. Anti-HB, yes, this is the answer. HB antigen indicates your replicative potential. Patients are viral load is highly replicating. HBs antigen indicates infection, it's not recovery. Right? So this is right, clear. So one important thing I want to discuss here, what are the questions they'll ask here is, patient is having hepatitis B surface antigen positive. Okay. And then comes patient is having hepatitis B, C, IgM is positive, it indicates acute infection. Okay. If same way IgG they are given, it's chronic infection. Very important. Okay. If hepatitis is negative and anti-HBS is positive, there is thing commonly they'll ask, it indicates your recovery. Okay. It is positive and this is also positive. Mostly it is your vaccination or recovery also, anything in government. So these type of things they are discussed. Just simple things only. You don't need to mug up also. Just see the concept. IgM stands for acute, IgG stands for chronic, E stands for replicated potential, and DNA for the viral load. Right? Right. Let us see the next question. Which of the following serological markers helps differentiate HBV, HDV co-infection from HDV superinfection? Here, what is saying? A patient is having hepatitis B virus and hepatitis D virus. Now, you want to know whether it is co-infection. They come together, or maybe on chronic hepatitis B. Now he is having HDV superinfection. That is what he is asking. So, whether it is HBV, HDV co-infection, that means they came together, or it's superinfection of hepatitis D on chronic hepatitis B. That is what is asked. Simple question only. Just see the options. If patient is having anti-HBC IgG, that indicates chronic hepatitis B. Okay, but does not tell about D infection has happened or not. Okay, and then anti-HBC IgM, it indicates acute hepatitis B. Okay, now for example, patient is having hepatitis D also. You check anti-HBC IgM, acute infection. So acute infection along with the D, so it indicates co-infection. If it is super infection, he will have anti-HBC IgG, right? If it's co-infection, definitely HBV IgM is positive because co-infection only. Because already having HD virus, IgM is positive co-infection. If it is super infection, patient will have HBV IgG is positive. Okay, clear? Remaining are some DNA is not related, HD is not related. Simple thing. So to know whether it is super infection or co-infection, that means patient already has hepatitis D virus. So whether it has come along with hepatitis B or come on a chronic hepatitis B is asking. Along with hepatitis B means hepatitis B, IgM is positive. That is acute infection. If along with chronic means IgG will be positive. Simple question. This is just only confusing terminology, right? Right. Very, very important now. This is very, very important. A health worker like our only interns or PGs had needle stick injury, okay, while handling a chronic hepatitis B case, right? She had taken 2 complete schedules of hepatitis B vaccine. She has taken 2 doses of vaccination, but she was tested and was diagnosed non-responder. First of all, what is responder? What is non-responder? We'll see. Now, what is the most appropriate management in this case? Let us see what is saying. So, what is non-responder? Responder. For example, if I take some hepatitis B vaccination, hepatitis B surface vaccination, okay, after some time, my body will develop anti-HBs antibodies. Okay, that means my body has developed some protective mechanism against your hepatitis B. So next time, anytime vaccine virus is entered, these antibodies will fight those things. So these are called as responders. So if anti-HBs titers are greater than 10, they're called as responders. If less than 10, they're called as non-responders. Simple. Okay, so after giving vaccination, you check the anti-HBs titers. If anti-HBs titers are more than 10, that indicates responders. If less than 10, they are non-responders. Right? Now, very, very important. Please understand this slide. Right. The first important thing. Right? For example, if a healthcare worker are getting HPV infected, if I get HPV infected, okay, if I have needle stick injury, okay, the first scenario is if I didn't get vaccinated before, not vaccinated at all, I'm not at all vaccinated. Okay, I didn't take vaccine before. Suddenly I got needle stick injury. So what I have to do is first immediately I have to take hepatitis B immunoglobulin for the passive immunity. Then I have to go for the all 3 vaccinations. Simple, right? Very simple. So suddenly if I get infected or if I get needle stick injury, I didn't take vaccine before. First I take immunoglobulin, that's a passive, there is some passive immunity. Then I can take vaccine for the further attacks. And second, if I am half vaccinated, for example, I have to take 3 doses of vaccines, but I complete only 1 or 2 doses. In between, I got some needle stick injury. Then you get again hepatitis B immunoglobulin and complete your vaccination schedule. Complete your remaining vaccination. Right? Simple. Simple. Then, if I am vaccinated completely, if I already took 0, 1, 6, 3 dose hepatitis B vaccine, and then I got needle stick injury. So what I have to do is I will check anti-HB status. If anti-HIV status is more than 10, that means I am responding. My body has produced already anti-HBs. So no need to take anything. No treatment required. Very important. No treatment required. Okay. If my anti-HBs is less than 10, okay, that means I am non-responder. Okay. Definitely I will take hepatitis B immunoglobulin. And again, go for vaccination. Okay. Okay. Now the thing is already vaccinated two times, but I'm not responding at all. I'm not responder, non-responder. That means my titers are not at all increasing. That means even though if I give hepatitis B vaccine, I'm not at all producing any antibodies. Then I cannot give active immunity. You have to give only hepatitis B immunoglobulin. In such condition, you have to give 2 doses, one at stat and other after the 4 weeks. Other after 4 weeks. So understand this thing, very, very important thing, okay? So for example, already needle stick injury, if not vaccinated, I've never got vaccinated, okay? If I never get vaccinated, if I get needle stick injury, I'll take immunoglobulin and then I'll take vaccine. Or if I half vaccinated, I will take immunoglobulin, then I'll go for the remaining vaccination. Okay, if I'm vaccinated also, I never get, I'll see the titers. If titers are completely normal, elevated, then no need to do any treatment only. If titers are not elevated, that means I'm a non-responder, then I have to go for hepatitis B immunoglobulin, 2 doses. Very, very important. Here only 2 doses because there is no point of giving active immunity in this patient. You have to give only passive immunity. I'll give 2 doses, one at stat and after 4 weeks, one more dose. Right? So see the question. This is the question they're asking. So what is the question they're asking here? So patient actually complete 2 complete schedules of 6 doses of hepatitis B. He complete 2 schedules, but he is non-responder. That means there is no anti-HIV status. That means even after giving this hepatitis B surface antigen, his body is not generating antibodies. That means active immunity is not useful for him. So what you will do? You have to give only passive immunity. So what will you do in here? Give 2 doses of hepatitis immunoglobulin, one now and another 4 weeks later. We discussed already. But give 2 doses of HBs now, it's not required. You have to give over a period of time, one now, and later after 4 months, 4 weeks, you have to give one more thing, right? And second thing is give HB vaccination starting now. You're not giving vaccination because already he is not responding only. Already 2 doses of vaccine is given. Why again you will give vaccination? So there's no point. HB is single dose with HB vaccination. That is not for the right. This is only for the partial responders. No, this is not there. Simple. This is very, very important potential question. New guidelines system. So this is what they're asking here. Okay. Simple thing. Remember this slide. Very important. This thing. If not vaccinated, take immunoglobulin, take vaccine. If vaccinated, see the response. If response is there, responders, okay, no need to do anything. If they're not responders, okay, give vaccine, give immunoglobulin, give vaccine. If they're poor responders, 2 times once they do the dose, then nothing, there is no point of giving active immunity, give passive immunity, 2 HBIG vaccine injections, one after another, 4 weeks apart. Right? Right. Let's go to the next question. A man doesn't derange elective, the serum viral marks are given below. Let us see. Anti-HIV IgG non-reactive, that means not acromegaly. Here anti-HIV IgG reactive, that means here chronic hepatitis A virus infection. Okay. Then HBsAg non-reactive, that means not infected only. He is not infected with hepatitis B. Accepted? Okay. Anti-HBc totally reactive, that means here some chronic HBc infection is there. Some chronic somewhere. Okay. Then anti-HBc IgM non-reactive. Okay. Anti-HCV IgM non-reactive. Okay. This again anti-HCV IgG reactive means is chronic HCV infection. Anti-HIV is non-reactive, non-reactive. Okay, fine. Which of the following is not correct about this condition? Is say. So what he mentioned here, based on mechanism, these are things react to here. Anti-HIV IgG. That means he is chronic HIV infection. Okay. One more thing is he gave HBsAg non-reactive. That means here he is not at all infected with the HBsAg right now. Okay. Other thing is anti-HBc reactive. That is some chronically before past you would have infected with hepatitis B. And second thing is anti-HBc IgG reactive, chronically got HCV also. Now, what is the thing here? Let us see the options. It's a chronic hepatitis B infection. Is it a chronic hepatitis infection? It's not infection at all. If chronic hepatitis B infection means he should have hepatitis B surface antigen positive along with the HBc IgG positive. Okay, but here there is no hepatitis B surface antigen positive. It's not reactive. So it's not infection. It's a chronic hepatitis infection. It's not infection. No need to check for HBV titers. That's the wrong thing. And HBV infection remote past, yes, this is correct. That's why he has HBc IgG positive. It's a remote past somewhere before it happened. That's why its HBs antigen is negative. Okay, and HCV DNA titer should be estimated PCR. Very important here because here he has anti-HCV reactive. we don't know this anti-HCV positive because of now or before, we don't know. We have to check for HCV DNA titers, HCV RNA titers, right? So that is also correct. And past HIV infection or received vaccine or HIV. Yes, HIV IgG is positive, it's past HIV infection. So this is the thing, it's wrong. So chronic, simple take home message is chronic hepatitis B is there. Okay, that means hepatitis B, C, IgG positive is there. Okay, is chronic infection or patient is recovered or remote infection. Chronic infection means he definitely have HBsAg positive also. In such condition, you check for the HBV DNA and then you can see for things. If it's recovered thing, HBs antigen is negative. That is the thing. Simple. Right? And whenever HCV infection is positive, you have to check for HCV DNA levels, HCV RNA levels so that you can decide the treatment also. Right? Simple. Right. Let us go for the next thing. Which of the following antidiabetics is their most characteristic feature? Very simple thing. So here you can see euglycemic ketoacidosis, generic macrodepression seen in SGLT2 inhibitors because they are glycosylated drugs. Because more glucose is going, they will cause more amount of fungal infections. And again, they'll have euglycemic ketoacidosis. There is potential complication of your SGLT inhibitors. And then lactic acidosis risk is seen in case of metformin. We already know. Okay. And then delays gastric emptying and leading to weight loss. It is seen in case of your GLP-1 agonist like liraglutide. These things. And weight gain is edema, you will see it's pioglitazones. All your anti-diabetic drugs side effects you have to remember. And increase endogenous incretin levels is DPP4 inhibitors. Okay. So just study the mechanisms of the anti-diabetic drugs, very important. So when you see this anti-diabetic drugs, okay, you can classify based on mechanism, simple thing. One is what is called insulin sensitizers, then insulin secretagogues, and they are glucosuric drugs. Simple. Insulin sensitizers, you have biguanides, that is your metformin. And insulin secretagogues, you have what is called sulfonylureas, that's your glimepiride, gliclazide, lepenclamide, all these things. And again, you have incretins. Incretins means they will increase the insulin after food intake, especially your GLP-1 agonists and DPP4 inhibitors. Very important. And glucosylate drugs are SGLT2 inhibitors. Very important. Okay. Metformin will cause lactic acidosis, we know. Okay. And sulfonylureas will cause definitely weight gain. Okay. GLP-1, these all things will cause weight loss. SGLT2 will cause euglycemic ketoacidosis. Right. Clear? Right. Okay. Let's go to the next question. So patient with history of antibiotics used for fever and sore throat. Okay. Patient already used antibiotics fever and sore throat 2 to 3 weeks back. Now present rash and arthralgia. Blood shows eosinophilia. Urine shows WS cache. What is the diagnosis? What is the diagnosis now? Patient already taken some antibiotics. Okay. Okay. After this, after some 2 to 3 weeks, he developed fever. He developed rash. He developed some arthralgia. And he developed some acute kidney injury. Okay. And he's having some eosinophils. Okay. All these things are characteristic of drug-induced allergic interstitial nephritis. Allergic interstitial nephritis. Right. So drug-induced allergic interstitial nephritis. Simple thing. So, see, the history they will give like this only. Patient is taking antibiotics after 2 to 3 weeks because of antibiotics. He developed acute interstitial nephritis because of allergic response. Patient has fever, patient has rash, patient has arthralgia, and clue point is eosinophilia because of allergic mechanism and also AKA. So let us see the options. What is giving here? The patient is actually fever, sore throat is there. He took 2 to 3 weeks antibiotics. Rash, arthralgia is there. Blood shows eosinophilia. Urine shows WS cache. What is the diagnosis? Lupus nephritis? No. The patient don't have any history of any arthritis or any this SLE manifestations. Acute interstitial nephritis, yes, we're discussing that thing. And then post-infective glomerular nephritis. So post-infective also could be possible here. Like post-infective, post-cryptococcal glomerular nephritis is there, it's possible. But okay, here they didn't mention about characteristic eosinophilia is there. There you cannot say any eosinophilia here. Instead, here your C3, C4 levels will be low. Or they can show ASO titers are high. That is the clue they will give. Okay, and pyelonephritis, there's nothing. Pyelonephritis is an infection, that's not a thing. So this is it. Right, simple. Right. The take home message is whenever you see acute interstitial nephritis, that means mainly most common are the drugs. They cause what is called allergic response. Okay. So what you will see after the drug history, after the drug intake, definitely patient will have fever, rash, arthralgia, AKI. When you see definitely eosinophilia, peripheral eosinophilia is a characteristic feature. When you see the peripheral eosinophilia, don't think anything. Just you can go for your allergic interstitial nephritis or acute interstitial nephritis. It's a self-resolving thing. Okay? Sometimes some people require steroids, some people don't. Now, what causes decrease in GFR? It's simple decrease in glomerular coefficient. Remaining nothing. So decreasing glomerular oncotic pressure and low pressure will have more GFR. Increasing glomerular hydration pressure, again more GFR. Decrease of Bowman's hydration because more GFR. So only thing is when I decrease glomerular coefficient, it have decreased GFR. Right? Clear? Next question. A patient presents cola colored urine, right? And mild edema. So cola colored urine means again hematuria. Okay. Urine microscopy as shown like this reveals dysmorphic RBC. This is a clue and RBC cast. So what is the question is asking? Which of the following is most consistent with this condition? Right. So presence of urinary crystals, dysuria is common, origin of bleeding glomerular, right? Gas. This is the important thing, right? So what I'm saying is you have to remember about what is dysmorphic RBC and what is isomorphic RBC, right? Dysmorphic RBC versus isomorphic RBC. Okay. So dysmorphic means here RBC shape is altered. RBC morphology is altered. Very important. So why this morphology is altered? Whenever the RBC is coming from the glomerulus, so in the glomerulus only, their RBC shape will be altered. So when you see the in urine, when RBC size is morphology is altered, that means it is coming from the glomerular. So the hematuria is a glomerular hematuria. Glomerular hematuria. Okay. If it's isomorphic, the same morphology is there, it is not coming from the glomerular, it is mainly tubular cause of hematuria. Tubular. Simple. So the question indicates here the patient is dysmorphic RBC, that means origin is glomerular. Because glomerular means small capillaries are there. RBC has to come from the small capillaries. Their morphology is changed. That is what is called as glomerular hematuria. Right? Clear. And simple, very important thing. A 14-year-old boy with known bleeding disorder present with recurrent painful swelling of large joints. Right? You understood here? Known bleeding disorder, recurrent painful swelling of large joints. That is your hemarthrosis. Hemarthrosis. So you will see mainly because of factor 8 or factor 9 deficiency. Factor 8 or factor 9 deficiency. So image is obtained during acute. This is what hemarthrosis. This is all white is your this knee joint around this blood accumulated hemarthrosis. In the absence of specific factor constant, which of the following blood components can be administered? Very, very important. This is a typical INICET question. Right? Right. So let us see. A 14-year boy has come with a known bleeding disorder. He presents with recurrent painful swelling. That means hemarthrosis. It's mainly seen as a factor VIII deficiency or factor IX deficiency. That is called hemophilia A and B. Hemophilia A and B. Okay. So what you is saying, let us discuss these things here. Okay. The patient can have hemophilia A or hemophilia B. Hemophilia A is factor VIII deficiency. Hemophilia B is factor IX deficiency. Okay. Now what you have to give? Definitely if you have factor 8, you have to give factor 8 only. But what he asks the question, if the patient don't have any, in the absence of specific factor constant, don't have any factor 8, then what of the blood components will you administer? Is asking. Okay. Let us see the thing. So factor 8 concentrate, he's saying it is not there. How will it be not there? And fresh frozen plasma. This fresh frozen plasma contains all clotting factors. All clotting factors. Okay. Fresh frozen plasma contains all clotting factors. And then cryoprecipitate. This cryoprecipitate contains only three things. One is factor 8 and factor 13 and von Willebrand factor. That's it. These are the only three things which is in cryoprecipitate, nothing else. And cryopoor plasma is also same. So now what is asking is if you have specific factor, you can give hemophilia factor 8 only. If there's no specific factor, what will you give? He's asked. So let us see what will you give. So this hemolysis can be because of hemophilia A or B. We don't know whether because of factor 8 deficiency or factor 9 deficiency. We don't know what deficiency it is. So when patient come to casualty, you don't have factor 8. So patient has hemoarthrosis there. You don't know whether it's A or B. You don't know whether to give factor 8 or 9. So what will you choose? You will give the thing which contains both 8 and 9. In these things, only fresh frozen plasma will have all clotting factors. So you can give this thing. But this thing, only factor 8 is there. It's not 9 is not there. So you won't give this thing. Because if patient has hemophilia B, then you're only giving factor 8. There is no point. Clear? This typical INICET bit, simple thing, simple concept only they mentioned, nothing else is there. So what it's saying is, if patient of any hemophilia patient, he comes with any hemarthrosis, you have to give factor replacement. So drug of choice is always factor replacement. Factor replacement. Okay. If this factor is not available, okay, if it is hemophilia A because of factor deficiency, definitely you can give cryoprostate. If they mention it is hemophilia A. If they don't mention anything, you don't know whether it's 8 or 9, you have to give fresh frozen plasma, which contains all clotting factors. Right, simple. Right. So regarding this one small thing, I would say different blood components. So when I say different blood components, packed RBC is there. Okay. Packed cell volume, whole blood is there. Platelets, FFP, and cryoprostate. Very important. These are the 5 components you have to know. Cryoprostate. Okay. And RBC contains only RBC. Whole blood contains whole blood, nothing else. Platelets only contains platelet. FFPs contain all the clotting factors, and cryoprostate contains your factor 8, factor 13, and 1 milligram factor. Very important. Okay, and this is just only 350 ml. This is some 450 ml. Okay, and all these things are some 150 ml like that, right? Nothing much. Right. And these two things you have to give at 2 to 6 degrees centigrade. Okay, and this platelets room air 24 to 25 degrees centigrade, and these two things are minus 18 degrees centigrade. Right, very important. Right, this is important things. And definitely cryoprostate you will give in only hemophilia, factor and all. FFPs you can give in any coagulopathies and all. Platelets will give thrombocytopenia, RBCs and all you can give in anemia patients. Clear? Right? Okay. Simple. Next comes next question. A 26-year-old female presents to ER with amenorrhea. ER with amenorrhea. Okay. She mentions that her father and sister also suffer from bleeding. Father is there, sister is there, she is also having. Which of the following is autosomal dominant bleeding disorder? Nothing else yet number. It is von Willebrand disease, and autosomal dominant. Factor 8 and all X-linked diseases and all. Right? So just study this slide of inherent patterns of bleeding disorders. Nothing much to explain here. Okay. And all are hereditary cause of thrombosis. We already know hereditary cause of thrombosis. I discussed mainly if any patient of thrombosis has come, you're checking for 3 things. One is factor 5 lead mutation, protein C deficiency, and protein S deficiency. Okay, all these are genetic causes of your thrombosis, hereditary cause of thrombosis. Of these things, factor 5 lead mutation is most common cause. Okay, so what are the hereditary causes? This is protein S deficiency, hereditary cause. Antithrombin deficiency, protein C hereditary cause. Homocysteine is also hereditary cause. So PNH is not hereditary cause. So what is this PNH? Let us see. So this PNH, if you see, it's paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. Right? So what is this paroxysmal nocturnal hemoglobinuria? Here what is going to happen is the patient will have complement deficiency. Okay. The patient will have glycoprotein deficiencies. That is CD55. So this glycoprotein is protecting RBCs from not undergoing hemolysis. Since this glycoprotein is not there, it will undergo hemolytic anemia. Slowly patient aplastic anemia. And the patient will have hepatic vein thrombosis. So this is a triad of PNH. Hemolytic anemia, aplastic anemia, hepatic vein thrombosis. And the most common cause of death is also hepatic vein thrombosis. So that is why it's just an acquired condition. It is not any genetic condition. So what is asking hereditary cause of thrombosis? So protein S deficiency hereditary, antithrombin hereditary, homocysteine hereditary, but PNH is an acquired condition. It's not a hereditary condition. Right? Simple. It is the most common cause of inheritance factor 5 lead mutation. I will discuss already. Right. Right. Okay. Right. Right now, we'll stop the class here. We'll just meet in the tomorrow class. So in this only some 20 questions are there. We'll cover these things and remaining questions we'll cover in the next class. So any doubts also you can ask. We can discuss now. So I think we'll stop the class here and we can meet in another class.